and HOD, General Medicine, Sri Ramakrishna Hospital, Coimbatore, Dr. G. Jnana Shanmugam, Senior Consultant Neurologist, CK Specialty Clinic, and Dr. M. G. Kaushik, Senior Consultant Neurologist, Kumaran Hospital.
Good morning, everyone. And I thank Dr. Asokan and the Department of Neurology for arranging this nice morning session. The first topic will be thrombolysis in acute ischemic stroke. So just like thrombolysis in acute MI, thrombolysis in acute ischemic stroke has become the order of the day. And every day in our emergency, we will get the calls of code stroke. So emergency treatment and care is occurring in Ramakrishna Hospital. So how to do thrombolysis in acute ischemic stroke will be dealt by Dr. Vedanayagam, our budding and popular neurologist, Dr. Vedanayagam. As you all know, the ischemic strokes are the most common strokes and compared to hemorrhagic strokes. So 90% of strokes are due to ischemic strokes, which can be due to thrombosis or embolism. So how to give thrombolysis in acute ischemic stroke? Dr. Vedanayagam will take over. Thank you.
Good morning and a warm welcome to everyone. So especially those who misses a cricket match and those who misses a subtle and early nap on the Sundays, thank you for coming and listening to my talk. This is thrombolysis in acute ischemic stroke. Every minute counts. So each minute 2 million cells will die. So we have to act fast. So the leading cause of death is stroke, and it is going to be the disability cause worldwide. And the global stroke rate claims, especially in India, there is 51% spikes in over the past and the upcoming 30 years. So we are going to face more number of stroke cases in future. So this everyone knows that this is, you can watch that there is the core where you have the permanent deficit will be there. So you can't reverse it. The next one is the penumbra, where you can able to salvage the brain tissue that is in the green. And the brain oligemic area, that is surrounding area, you can able to, it will revive on its own. So same slide, it shows the impact core. It leads to functional deficit that will be permanent, and you can't do the revascularization. Whereas in the penumbra, you can do the reperfusion. That is our aim, to revascularize the penumbral area. So primary aim is to recanalize the vessels and make you all to thrombolize even without any hesitations. So even in our house surgeon period, we used to thrombolize all MI cases. But in our settings, stroke thrombolysis is so difficult. We are facing so much struggles. So which type of strokes we are going to thrombolize, and up to what time we have to do thrombolysis, and fear of bleeding will be there, and huge list of indications and contraindications are there. This is the struggles we are facing nowadays. So my talk is on this to avoid your hesitations, and you can make you all to thrombolysis without any hesitations. Even without seeing CT, you can do thrombolysis after my talk. That was my aim, but we'll see what it goes down. So we know that etiology of stroke is atherosclerosis, followed by other causes like cardiac diseases, hematological disorders, prothrombotic state like protein C, S, and deficiency, infections like TB, HIV, and vascular causes like moya, aneurysm, and metabolic paraneoplastic vasculitis and drug-induced. These are the common causes. Apart from the atherosclerosis is the most common cause, where we have the hypertension, obesity, diabetes, alcohol, smoking, everything. Everyone knows this. So my talk is on this. Don't bother about the etiology. If you know that there is a infarct, you can go with the thrombolysis. Then next one is the pathophysiology of stroke. Usually the pathophysiology is either the thrombotic stroke or embolic stroke. So whether it could be a small vessel or large vessel, don't bother about it, you can go with thrombolysis. If it is embolic or thrombotic, don't bother, you can go with thrombolysis. And this is the stroke syndromes. These are the cases we are going to face in our clinics. That means either large vessel occlusion or branch vessel occlusion. Don't bother about the vessel occlusion. Our aim is to recanalize the vessel. So straight away go with the thrombolysis. Don't bother about the syndromes. If you see, if there is any stroke, go with thrombolysis. So irrespective to the stroke, depends upon the etiology, pathology and the vessel effects, don't bother, you can go with thrombolysis. So in acute treatment, there are 4 ways of treatment. One is thrombolysis, then is thrombectomy, and the 3 is bridging therapy, both thrombolysis and thrombectomy, and the 4th is neither of the above, that is conservative and physiotherapy. So up to second question, up to what time we can do thrombolysis? Up to 24 hours we can do thrombolysis. But earlier the treatment, better the outcome. That means every minute counts. Each minute 2 million cells will die. So we have to do thrombolysis as early as possible. So if it is less than 4 point, the patient present with less than 4.5 hours, you can do thrombolysis. If there is any large vessel occlusion, don't bother. Or small vessel occlusion, don't bother, you can do thrombolysis. If it beyond 4.5 hours, you do the CT perfusion study or MRI perfusion study or MR diffusion perfusion mismatch. From that you can be able to know if there is any mismatch, you can do thrombolysis up to 24 hours. That is chemical thrombolysis. So it is a concise paragraph of the above chart where you can do thrombolysis less than 4.5 hours. If it is more than 4.5 hours, you can do both thrombectomy and thrombolysis, check with the mismatch. If it is beyond 4.5 hours, either still you can do thrombolysis if there is any mismatch. If it is large vessel, directly you can go with thrombectomy. That is a concise slide about thrombolysis and thrombectomy. So next thing is which drug to choose. So usually these are the drugs for thrombolysis, the tenecteplase, alteplase, retiplase and streptokinase. These are the drugs evaluation, but we are using tenecteplase because it has advantage over the alteplase. You can observe that the plasma half-life is some 20 minutes, where it is 6 minutes in the alteplase. Next thing is the plasminogen activator inhibitor resistance. It is highly resistant to PAI. That means it has more effect on the clot. And the next thing is, it is fibrinogen specific. So it won't cause us much more bleed in case of thrombolysis. And next thing is the liver metabolism. So don't bother about the kidneys. The next thing, why we are here, why we are advising go with the thrombolysis even your own setup, because only 10% of the patients we are getting thrombolized. That means out of 25 patients are eligible for the thrombolysis, only 10 are getting thrombolysis treatment. And the percentage, when you go with thrombolysis, the mortality falls to 10%. So if you want to reduce the mortality, go with thrombolysis. Next thing, I give a concise case history. And will you say able to thrombolyze or not? The patient is 61 years male, presented with hypertension, diabetic and dyslipidemic. CKD, he presented with CKD 3.6 milligram, not on dialysis. He presented with acute aphasia and right hemiplegia with a window period. Will you thrombolyze this case? Yes, I already told you can go with thrombolysis. Don't bother about the kidneys because the drug is metabolized by the liver. Don't bother. This is a case where you can see the diffusion, there is a diffusion acute infarct in the left frontal area. This is a flare image where you can see there is no flare changes. That means it is evolving infarct. So you can go with thrombolysis. This is a vessel wall imaging where it shows the thrombus and the left M1. So now we did a thrombolysis with the tenecteplase, the vessels has opened well. So don't bother about the kidneys, go with the thrombolysis. So still we are scared of thrombolysis because of fear of bleeding and huge list of indications and contraindications, and we are missing our basics, not going to depth into the neurology. If you think about the logics and basics of therapy, you can go with thrombolysis. That I am going to deal with the next slides. So to overcome the fear of bleed, we must find a reason to thrombolyze. We must admit the difficulties to thrombolyze. So bleeding rate is only 2%, less than 2% with the tenecteplase. So straight away you can with thrombolysis. And mortality rate is 10% in case of thrombolysis, where it is non-users, it is 14%. So better you you can go with the thrombolysis. So usually we have to, during thrombolysis, we have to reduce the BP. If it is BP is more than 185/110, we go with the BP reduction. Then we used to do the setup. We used to keep the BP little bit low. That means 165/110 is enough for us to do. Usually 160 is systolic and 85 is a diastolic, ideal BP for thrombolysis. And for thrombectomy also the same BP, 165 to 180 is accepted, and thrombolysis and thrombectomy 185 is accepted. Not doing anything means don't reduce the BP, because if the perfusion pressure depends upon the BP, don't reduce the BP. If you are not going to do any interventions, don't reduce the BP. And the next thing is, if you are able to know the clinical situation better, then you can thrombolyze very easily without knowing or without performing any studies on that. That means if you are able to manage the bleed, like in the eye bleeding, nose bleeding, uterine bleeding, if you are able to manage the bleed, you can go with thrombolysis. That means if the patient presents with epistaxis and stroke, don't bother about epistaxis. You can manage epistaxis with the package. So, you can do the thrombolysis. And if the bleeding source is already treated, that means already aneurysm has been treated well, it presented with subarachnoid hemorrhage, then it is a case easily you can go with the thrombolysis. And recent surgery, even with the CABG, the healing time is 3 weeks. Every surgery in cardiac or abdominal surgery, the healing time is 3 weeks. If it is more than 3 weeks, you can relatively you can go with the thrombolysis treatment. And another thing is GIT bleed is 3 weeks. And traumatic bleeding, even the major bleed, you can do thrombolysis after 3 months. If the BP is more than 180, I already told you have to control the BP and do the thrombolysis. And if the patient is taking aspirin and clopidogrel, don't bother about the drugs, you can go with thrombolysis. Even the patient is pregnant, you can go with thrombolysis, don't bother about the child, because the stroke is devastating condition, you have to do the thrombolysis with the explained risk. And these are the conditions you can't do thrombolysis, like spontaneous bleeding disorders. That means spontaneous, you can't control that. So spontaneous subarachnoid hemorrhage, subdural hemorrhage, and platelet less than 50, don't do thrombolysis. And the patient in combination with the ticagrelor aspirin, prasugrel aspirin, that times you don't do the thrombolysis, because it acts on permanent inhibitor, 2AB inhibitor. So don't do thrombolysis. And malignant brain tumors, don't do thrombolysis. Systemic malignancy, if it is active bleeding, don't do thrombolysis. In the vascular anomaly, don't do thrombolysis, especially on the AVM and cavernoma. So these are the clinical situations. With pediatric stroke, you can do thrombolysis, that is indicated now. And age is not a bar, you can thrombolyze up to 96 years. And the pre-existing disability, if it is severe disability, the patient is about to die within 3 months, don't do thrombolysis. And ischemic stroke, recent stroke, that is less than 6 weeks, again the stroke, recurrent stroke, you can do thrombolysis if it is small. If it is large, more than 3 months is indicated. If it is a silent stroke, yes, you can go with the thrombolysis. And SAH, if it is treated completely, you can go with thrombolysis. And hypertensive bleed, it is a relative contraindication. If you are able to control the hypertension, you can go with thrombolysis. Previous hemorrhagic stroke, don't do thrombolysis. And subdural hematoma, don't do thrombolysis. And hygroma, you can go with. Hygroma, it is a chronic condition, you can go with thrombolysis. If there is a microbleeds in the brain, still you can go with thrombolysis if it is a microbleeds less than 10. And active intracranial malignancy, don't go with the thrombolysis. And if it is malignant tumors, it is okay. And the benign intracranial tumors, it is okay for thrombolysis. And systemic malignancy, if there is no bleed, you can go with thrombolysis. And asymptomatic cerebral aneurysms, like aneurysm less than 10, you can go with thrombolysis. If it is more than 10, don't go with the thrombolysis. And the next thing is vascular anomalies, like AVM, don't go with thrombolysis, and cavernoma, don't go with thrombolysis, because it will bleed like anything. So other things like developmental anomalies and capillary telangiectasia, you can go with thrombolysis. And platelet less than 50, don't go with thrombolysis. And INR more than 1.7, don't go with thrombolysis. And the history of bleeding diathesis like coagulopathy, if there is a reason, don't go with thrombolysis. If it is remote, that means more than 3 months, you can go with thrombolysis. Internal bleeding also same. If there is any GIT bleed recently, that means less than 3 weeks to 3 months, you can go with thrombolysis. That means remote you can go with. Aortic dissection aneurysm, if it is completely treated, you can go with thrombolysis. Otherwise, don't go with thrombolysis. Other conditions like aspirin, clopidogrel, I already told that you can go with thrombolysis. And ticagrelor and prasugrel in combination, don't go with thrombolysis. And anticoagulants, don't go with thrombolysis. A major surgery and biopsy, it is not a contraindication if it is okay. The lumbar puncture is okay for thrombolysis, and intracranial spinal surgery, don't go with thrombolysis. Angiography, it is okay for us. And PTCA is okay. Even the CABG is okay for us within after 2 weeks. So endocarditis, any infections, septic shock and septic embolism, don't go with thrombolysis. Endocarditis, don't go with thrombolysis. Pericarditis, if it is okay, with the effusion is not a much problem to the cardiologist. And myocardial infarction, it is okay. Even the septal impact, we have to be careful. Otherwise, it's okay for thrombolysis. Vasculitis, it is okay. Don't bother about the etiology of the stroke. You can go with thrombolysis. So during menstrual cycle, during menstrual cycle with the stroke, you can go with thrombolysis. And the active menorrhagia without major anemia, you can go with thrombolysis. Pregnancy also, you can go with thrombolysis. Postpartum, it's okay. Even now, even stroke mimics, pseudo stroke, that even patient without having any vascular occlusion, patient may present a stroke. We used to do the CT. If there is no active infarct, then go with thrombolysis. Even with it, stroke mimics like diabetes and pseudo stroke, you can go with thrombolysis. And now you can read the absolute contraindication. Now it is easy for you to understand when to thrombolyze, when not to thrombolyze. Old hemorrhagic stroke, these are the absolute contraindications. And hypertension, recent head trauma, thrombocytopenia, coagulopathies, these are the contraindications. And these are the relative contraindications. Severe stroke, recent surgery, arterial puncture, GA bleed. These are, I told, you can go with thrombolysis. It is a relative only, you can go with thrombolysis. So why we are doing thrombolysis? Because the complete recanalization we want to achieve. But in large vessels, only 50% of the persons will have a. For M2 it is 68, M1 it is 53, and carotid is 46%. So conclusion, if the patient comes with the window period, we should find a reason to thrombolyze and amidst the various difficulty situations, we have to do thrombolysis. And thank you for my PG. And I end with my talk with this picture. This is Ayodhya Ramar temple where I visited last week. You can see my smiling face because it's a Ramar birthplace, and this slide it shows Rama's death place. That means that Ramar dies on that self-immersion into the water and dies by he ends his life by this Sarayu river. So thank you for the patient attendance. Thank you.
Now the session is open for questions and discussions.
Excellent talk. It's for the newcomers, it's very mind-opening talk. I like to emphasize a few points about stuttering stroke. When to consider as an onset, when to thrombolyze stuttering stroke. Stuttering.
So carotid stuttering.
Carotid stuttering or basilar artery stuttering?
Basilar stuttering. So carotid stroke, the scenario is different because the patient may have stroke 2 days ago, and again they come with the stroke on the 3rd day or 4th day, like that. So if you do the mismatch, that is diffusion perfusion mismatch, if there is any mismatch, you can directly go with thrombectomy or thrombolysis. That is ideal situation. If it is small impact, you can go with thrombolysis. If it is large vessel occlusion stuttering, then go with the thrombectomy, direct thrombectomy. And the same thing for the wake-up stroke also. If the patient comes with wake-up stroke, if there is any mismatch in the perfusion-diffusion mismatch and diffusion-flare mismatch, you can go with thrombolysis. Even we did a stuttering stroke 36 hours after the stuttering stroke onset. We did a thrombectomy and thrombolysis, both combined. So previously stuttering stroke was TIA. Now it is called a stroke. Stroke.
Any questions from audience?
Thank you, Veda. That's an excellent presentation. I have 2-3 points. One is you mentioned, the basic rule is that find reasons to lice than not to lice. Previously, when in 2000s, when we used to give the TPA, it used to be very scary, like sitting with the patient for 1 hour, and I've seen various new findings new focal deficits happening during the thrombolysis,
Yes,
suddenly stopping, taking the patient for CT, again bring them back, and those kind of nightmares are gone now. Just one shot therapeutic place has been very useful. So I think one of the things which you should stress is the use of heparin.
yes, sir.
Now in peripheral centers, when the patient goes with a stroke, generally they are loaded with dual antiplatelets and they're also given
Plus
heparin. I think that kind of practice can change because especially giving heparin, for example,
Yes, sir.
giving antiplatelets may not be a big contraindication for lysis as they reach the hospitals, but giving heparin, though they say that one dose of heparin may not be a full therapeutic dose of anticoagulation, but then that further decreases the chance of lysis when they reach the stroke ready centers. So most of the when you go to the outreach centers and the villages and you give talks, I used to say that you start lysis.
Yes, sir.
And as you rightly point out, all cases are candidates for lysis unless proved otherwise. That's the most important message which you are conveying, that find reasons to lie. So all the small centers can lyse and send the patient rather than giving this heparin and dual antiplatelets, which generally do not serve any purpose at that point of time. Especially the heparin, that can be avoided at the periphery. That is my first point. Second is the stuttering. Generally, there are one or two ways in which. One is a capsular warning syndrome. That is, you get a TAA and then patient improves. Then after 12 hours, another TAA in the same territory improves. Then he might be reaching you with the third TAA. So what generally is the guideline is that if you have a deficit, the patient complains of a hemiparesis, but 2 days back he had this, that and all, but you can take that particular event with which the patient presents as the index event. For example, at 5 o'clock in the morning, the patient presents with a hemiparesis, has had some events the previous day, but that 5 o'clock event can be taken and you can proceed as if that is the first stroke.
Onset.
And evaluate, and then if the patient has NIHS more than 6, you can go for the treatment. But in the capsular warning syndrome, where it's more of a TA with less of deficits, you have to go for potent antiplatelets. For example, the terafuse infusion might help in those situations. Many data is there where terafimine infusion is very useful in the capsular warning syndrome, where it is the small vessel disease. It's all small vessel disease where the pathophysiology of more of the platelet aggregation. So that is one more point which I wanted to tell.
Yes, sir.
So these are the things which cross my mind.
Sure, sir. Definitely, the heparin is a relative contraindication for us to do the thrombolysis, and we have to do factor 10A activity level to thrombolyze or not. That is very difficult for us to get a report and do the thrombolysis. Even with a single dose of heparin, if you go with the thrombolysis, patient may have a bleeding. So it is better to avoid heparin in clinical, outside clinics. Wake-up strokes. Approved, sir. Still not approved. But still we are doing thrombolysis even up to 24 hours. Depends upon the situation and mismatch.
Yeah, thank you, Dr. Rajesh, for your clarification. And just one point I would like to say, the capsular warning syndrome, or whenever deep penetrating vessels are affected and you get stroke, such of these vessels are not opened up well with your trunnictor place. We have seen clinically.
Yes, sir.
And
branch vessels.
Yeah, branch
penetrating
vessels. Yeah, where they don't open with the lysis. And capsular warning syndrome, once warning, they end up with a stroke somehow. As Dr. Rajesh told, maybe tirofiban you can try, antiplatelet, such of those cases. And another thing, this BP business, even though this thing says 180, 110 is the cutoff, and less than 180, 110 you can safely thrombolyze. Still I feel clinically, 160, 90. If it is more than that, still there is tendency to bleed. So try to bring down the BP.
Less than 160.
Yeah. And now people are talking about thrombolysis up to 24 hours.
Yes, sir. Yes, sir.
With a good mismatch, etc. So if the BP is high, try to bring it down 160, 90 and below. We are very safe, very safe. But practically we have seen people with 180, 100, 170, 100, still we have bleed. And the third point is coagulopathy. coagulopathy is a risky factor. You said nothing happened, no bleeding occurred in the past 3 months, still there are candidates for coagulation therapy, I mean anticoagulation therapy, I mean thrombolytic therapy.
Yes, sir. Sir,
Thrombolytic
coagulation disorder, don't do thrombolysis.
He said coagulopathies and coagulation disorders.
Treated disorders. If it is treated
Uh,
3
that's-
months ago, you can go with.
Difficult to say. That's what coagulopathy or
Yes, sir,
coagulation
understand,
disorder. You should be very careful in doing
Maybe my
thrombolysis.
message carried in a wrong way, I think so, sir. The coagulation disorders don't do thrombolysis. If it is a recent bleeding in the GIT or is, even with the surgery, large surgery, even with more than 3 weeks to 3 months, it is okay for thrombolysis. Coagulation disorders like protein C, S deficiency, like that you are studying, sir. Bleeding disorders, bleeding diathesis. That is absolute contraindication for thrombolysis.
ICAS. We see very bad intracranial atherosclerotic disease
ICATS.
with the frequent use of cerebral angio. And there is a tendency for us to use dual antiplatelets in those scenarios, especially ticagrelor. So if,
Yes,
if
sure.
we have very significant intracranial stenosis, aspirin ticagrelor combination has become very commonly used in neurology, as frequent as it is used in cardiology.
Cardiology.
So these patients, when they come for stroke, it is not, what you have mentioned is an absolute contraindication. It is not, I think it's a relative contraindication only. Like any other dual antiplatelets, it's a kind of a, you have to, you have to see the pros and cons.
Oh, sure.
Ticagrelor per se does not confer an additional risk of bleeding if you are having aspirin also together. But prasugrel is an absolute contraindication for thrombolysis. Or, I mean, generally we don't give prasugrel for any stroke because it's very bad for the brain. But ticagrelor plus aspirin, you will have many scenarios of patient coming up and becoming candidates for lysis. It's only a relative contraindication, and I think we can give lysis in those
Okay,
situations.
fine, sir.
I want to point out one of the social aspect of thrombolysis. So whatever you are speaking about thrombolysis here, or about the patients in the city who are coming to the hospitals, stroke-ready hospitals, and there are a lot of secondary centers around any cities. So lot of stroke patients. So are they getting thrombolysis? Then the answer is no. So either the patient is not referred to the stroke-ready centers at proper time, or the patient receives medications like heparin, spontaroid heparin and dual antiplatelets before reaching stroke-ready centers. So most of the thrombolysis eligible patients are not getting the benefit.
Yes, sir. True, sir.
So probably we have to form a network, especially all the neurologists in the city should sit together and form a network. And we have to reach the nearby hospitals and to create the awareness. I think it's not possible with a single person or single hospital. Probably you have to form a network.
Yes, sir.
Yeah, it's an
I totally
excellent
agree.
point by Jnana Shanmugam, like what they did in cardiology, the STEMI program and all. I think all the peripheral hospitals should be concentrating on lysis. I mean, we are all trying to say repeatedly that there is no, most of the time there is no contraindication for lysis. Find reason to lyse than not to lyse. So I think we should empower all the peripheral centers, even in Ooty. They are all scared. I think there should be a kind of giving confidence to the peripheral centers and even in the far off place. So I used to tell them, it just lyse if there is a focal deficit. I mean, as Vedanagam nicely pointed out, the chance of landing up in some trouble is very, very less. And after lysis, immediately send the patient. And after that, we can see like whether it is enough or we can go for a thrombectomy or not. But the empowering all the peripheral centers with, especially after the arrival of tenectase, because it takes away the 1 hour time of TPA and you lose out on the time for a mechanical thrombectomy when you give TPA. This is a one-shot, easy to be administered drug. I think the telemedicine can be used as a mass movement and somebody can take it up as a mass movement and then empowering every peripheral center who receives acute stroke to thrombolyze. And that will be a major movement which can probably improve the stroke outcomes in our setup.
Yes, sir. True,
What
sir.
is the role for novel oral anticoagulants indications in ischemic stroke?
Sir, oral anticoagulants are indicated in 4 clinical situations, sir, like AF, vascular and atrial fibrillations followed by valvular disorders like MS, MR with arrhythmias. That is one indication. And the dissection with the thrombosis where we use anticoagulants. Otherwise, there is no role of acute treatment of ischemic stroke. There is no role of anticoagulations. Even in the heparin is no role. Only aspirin has a role. Others are not yet proved, followed by thrombolysis. So in follow-up cases, it depends upon the clinical situation. If it is embolic stroke, it needs anticoagulation. Otherwise, nothing required anticoagulation. Only antiplatelets. Dual for 90 days, followed by single antiplatelet for the rest of the life.
If there are no other questions, we will wind up the talk. And I thank Dr. Asogar and the team for the excellent speech.
Thank you, sir. Thank you.
Thank you, Doctor, for advancing the understanding of the critical golden hour interventions in stroke management. As a token of our gratitude, may I request Dr. C. Christopher Mariadas, Senior Neurologist, St. Luke's Hospital, to hand over a small gift to the speaker and chairpersons. Thank you all. Our next session brings forward the less trodden path, rare causes of ischemic stroke. To illuminate this topic, we have Dr. K. Aruna Devi, Consultant Neurologist, Sri Ramakrishna Hospital, Coimbatore. The session is chaired by Dr. V. Arul Selvan, Senior Consultant Neurologist, Royal Care Hospital, Dr. M. Arun Shivaraman, Consultant Neurologist, NG Hospital, Dr. K. Chinnaswamy, Senior Consultant Physician, Sri Ramakrishna Hospital. And Dr. Shaktiraj, Senior Consultant Neurologist, Surya Medical Center.
Good morning. It's my privilege to introduce Dr. Aruna Devi, one of the best neurologists in Sri Ramakrishna Hospital under the leadership of Dr. Asogan sir. She has presented so many interesting neurological case studies in national and international conferences and published many papers. Now she is going to present rare cases of ischemic stroke. Now hand over the mic to Dr. Aruna Devi.
Thank you, sir. Thank you for the introduction. I'm standing in between thrombolysis and endovascular management of ischemic strokes. Just a slow session with some interesting cases that we have encountered. Probably a few will be very interesting to us. So just going straightly to the cases. This is about Ms. G. She was 20-year-old female. She was working in a private sector, came with complaints of giddiness and paresthesia of the left half of the face and upper limb for 1 day duration. And it was acute in onset, and she didn't have any past medical history. She was not a known hypertensive diabetes or a coronary artery disease patient. She didn't have any rheumatological issues or hematological disorders previously. Initial examination was normal. Vitals were normal. GCS was fine. She had only UMN palsy with right ectaxic hemiparesis. The cardiac and systemic examination was normal. So the diagnostic MRI was done. It showed infarct in the left internal capsule, a small one, and MR angiography we did with it showed some wall thickening with enhancement in the left supraclinoid internal carotid artery, and it was infarct was secondary to the vessel wall thickening. So a possibility of vasculitis was considered in a young female without any other comorbid features. This was the MRI, and here is the small infarct that was made out. Infarct is present in flare also. So we did the other cardiac workup, including echo, TEE. There was no PFO. There was no other shunt. We also did an iotogram to see any other, if it is a possibility of other vasculitic involvement in the rest of the vessels, and which was normal. CT iotogram was also normal. The vasculitic workup, including ANA was 2+, and the other vasculitic profile was negative. So probably this patient we considered secondary to an isolated CNS vasculitis, though the diagnosis of isolated CNS vasculitis per se will not be coming up with a brain biopsy or a CSF involvement, but since the other informations were negative, other vasculitic pathology in the rest of the vessels outside brain was normal, we thought it could be a possibility of primary CNS vasculitis presented with an young stroke with an ANA positivity. So we started her on methylprednisolone and dual antiplatelets. Now she is on immunosuppression also. So the learning points in this is any patients with young stroke mandates an aggressive search for non-traditional etiologies. And MRI is crucial to find out for the if there is any vessel wall inflammation or vessel wall pathology, and it also requires a multidisciplinary approach and follow-up for long term, and this patient also will require long-term immunosuppression. Coming to the second case, Mrs. K, she was a 50-year-old teacher from Avinashi. She had sudden onset of weakness and paresthesia of the left upper and lower limb, and she presented to the OPD beyond the time that we can thrombolyze. She was not a known case of diabetes, hypertension, rheumatic heart disease, or a previous history of stroke. She was conscious oriented. She only had left faciobrachial monoparesis with a normal BP. Her basic investigations were normal. ECG and echo were within normal limits, and she had only ANA positivity. And this was the infarct that she had in the right corona radiata. And she also had small infarcts, lacunar infarcts. And she had multifocal infarcts in the right basal ganglia, corona radiata, centrum ceviomate, and also in the and also had distal ICA occlusion. We did a CT cerebral angio, which showed a near total occlusion of the supraclinoid portion of the right ICA up to the origin of the right MCA, and short segment total occlusion of the proximal A1 segment of the right ACA also. Patient improved with antiplatelets and supportive drugs and steroids since she was ANA positive. She was discharged with the dual antiplatelets pending the report of ENA profile, and we had advised DSA at the earliest. She was admitted within 15 days, readmitted with new onset weakness and a left upper and lower limb weakness, so she was again investigated. This time she had infarct in other place in internal capsule, and she also had, and so we did a DSA this time, and it showed critical stenosis of the supraclinoid ICA, proximal MCA, and anterior caudal artery, and which was Moya pattern. And the ENA profile, which we had repeated the second time, showed ANA positivity, SSA, SSB positivity, and lupus anticoagulant was negative. So she was diagnosed to have recurrent right MCA stroke, probable primary Sjogren's syndrome with secondary CNS vasculitis with moya-moya pattern. As her disease was active, we immediately started her on rituximab and steroids. She had multiple episodes of small strokes when she was in the hospital, so we didn't want to take a risk to send her again, so we started her on rituximab right away. Patient was re-evaluated at Chitra and she was confirmed the same, and they again did a vessel wall imaging which showed same enhancement in the right clinoid, the supraclinoid ICA. And negative remodeling which was suggestive of, without any negative remodeling which was suggestive of vasculitis. And a salivary gland biopsy was also attempted which was negative at that time. Patient completed 3 months of rituximab. Presently she is on MMF and tapering dose of steroids. She is doing well except that she has developed diabetes after the onset of when we had given steroids, and probably her age also, and there is no further TAS. She is doing well. And coming to the next case, Mr. X, this was a 14-year-old boy. He was studying in 9th standard. He was a right-handed individual from Erode. He just presented with double vision and headache for 5 days duration. And he had history of critical limb ischemia, for which thrombectomy was done a few days back, and he also had a right toe gangrene. His right decreased vision, he has right eye decreased vision and diplopia only. His investigation showed a low hemoglobin with a MVP. I have some water. And he also had some acute watershed infarct in the left frontal and occipital lobes with multiple T2 flare hyperintense lesions in bilateral frontoparietal subcortical deep white matter, which was consistent with vasculitis. His ANA profile was 3+, ANCA lactoferrin positive, and his APL, thank you, lupus anticoagulant and anti-cardiolipin antibody was positive. So this was a case of Apla syndrome presenting with peripheral vasculitis previously, now presenting with a stroke. So this was a young stroke, probably a vasculitic infarct with diplopia with phospholipid syndrome associated with MVP. He was treated with steroids, MMF, ecosprin and acetone, and he is completely recovered and is on regular follow-up. And going to the next case, Mr. S. He was 44-year-old, admitted with weakness of the left upper limb and face of 2 days duration. All these patients were not fit for thrombolysis, and they had all come slowly with a low NIHS and was seen in the OPD. He had only left hemiparesis with left human facial palsy, and he was a smoker. His MRI showed some infarcts with restricted diffusion with flare intensity, hyperintensity, and MRI visualized segments showed evidence of normal flow. His hemoglobin was 19.8, PCV was 56, homocysteine levels were just elevated, HbA1c was very high, and others written was normal. So we thought probably a polycythemia was contributing to the problem, so we had sent all the JAK mutation, MTHFR gene mutation, etc. And we didn't get a JAK mutation positive in this patient, we only had MTHFR, which was only heterogeneous positive. So actually this MTHFR mutation may not be a very typical mutation that we need to test. This was just a workup that we had done. We had done a workup for polycythemia, and so we had sent to this MTHFR also. And this patient was treated with vivisection. So because his hemoglobin was very high, we had to do 2 vivisections and regular antiplatelets and diabetic control. The patient became all right. So this was a case of not a regular case of stroke with atherosclerosis alone as the main factor. This patient had probably polycythemia and hyperhomocystinemia with new onset diabetes as the cause of stroke. So aggressive management of polycythemia was done, and endocrinological evaluation and treatment was done for the same. This is another cases of with hematological problem. Mr. K, he was hailing from Karur with complaints of left upper and lower limb weakness of 3 days duration. He was treated at initial hospital in an outside hospital, then referred here. His BP at presentation was 190, 110. His upper limb power, he had almost hemiplegia. There was no significant past history for this patient. But his hemoglobin was also very high, 19.4. His WBCs were 53,000. His platelets were normal. Homocysteines was just high. His B12 was normal. His peripheral smear showed only polycythemia and leukocytosis. His brain showed, DWI images showed some infarcts in the watershed territory, right MCA, PCA watershed territories, and with echo was normal. Ultrasound showed only mild splenomegaly. So this patient we sent for JAK2 mutation, which was positive. BCR ABL is awaited, possibly because 53,000 was the WBC count, and by the time we discharged him, it came down. We actually started him on hydroxyurea when he was in the hospital itself. So we had done 2 vinisections for him also. Polycythemia was better, and hematological workup was done along with hematologist, and patient is now on hydroxyurea, 500 milligram BD, and his count, his hemoglobin has come down, and his WBC has also come down to around 20,000. He has also come for review and doing well. So this patient, we wanted to show the hematological link, a patient with probably a myeloproliferative disorder with stroke. And the next case is a 63-year-old female patient from Erode. She presented with headache and vomiting, with weakness of the left upper and lower limbs, was treated in an outside hospital with CT for vomiting alone, where CT brain was taken. She was found to have a right frontal infarct, so came to Coimbatore for further management. She is a known case of diabetes with irregular management. We welcome our Ellen sir. Welcome, sir. On examination, she was drowsy, arousable, with a restricted left gaze. Her vision was decreased. She had bilateral papilledema. There was no other cranial involvement, and presented with a left hemiparesis of 3/5. MRI brain showed left parieto-occipital infarct with a hemorrhagic transformation, with a complete occlusion of the right ICA. Other investigations are normal, except for severe hyperglycemia, which was being managed. This is the MRI, and this shows the right ICA occlusion right from here. And she had bilateral severe sinusitis, for which ENT opinion was sought, and was found to have fungal sinusitis. She was subjected to FES and biopsy along with debridement. She was found to have diagnosed to have invasive fungal sinusitis, and started off on amphotericin and renal and was monitored with renal function and electrolytes. Patient developed elevated renal parameters along with hyperglycemia and hypomagnesemia. Then we had changed from the conventional amphotericin to liposomal amphotericin, and patient got discharged AMA because they were not able to manage the cost. 3 days later, patient was readmitted again with left hemiplegia. That was hemiparesis, now with hemiplegia, and the infarct had increased, and MRI showed complete occlusion. She was again treated with for renal parameters were becoming normal. So again we started on conventional amphotericin because of the cost issues. And she was completed around 6 weeks of amphotericin was completed, and her clinical hemiparesis also improved, after which we converted into oral posaconazole and discharged the patient. So patient was almost discharged with a power of 3 to 4/5, and now almost near normal. And coming to the last case, Mr. X, 36-year-old patient from Coimbatore. This patient was admitted during the COVID period with complaints of acute onset behavioral changes of 1 week duration. There was no previous history of typically of migraine, vomiting, limb weakness, seizures or speech difficulty. There was no diabetes, hypertension or tuberculosis history also. Vitals was stable, patient was drowsy, poor comprehension, fluency was decreased, not much of motor deficits. He had acute lacunar infarct in bilateral parieto-occipital frontoparietal regions, genu, corpus callosum, corona radiata and symptoms of semi-ovale with the possibility of CADASIL. This patient came in the COVID period. So this picture without a history of migraine, previous TIAs, probably this could have been the first, but we thought whether it could be some new presentation of COVID. But he was also positive for COVID, and his echo Holter was normal, blood investigation was normal. The picture, the MRI picture was typically of a CADASIL. This is the MRI picture. So we had to send a Notch3 gene, which was positive. Notch3 gene was positive, and probably diagnosed to have an acute CVA, probable CADASIL, Notch3 gene positive with the COVID-19 pneumonia. He was given dual antiplatelets and statins and neuroprotective drugs. He again got admitted 3 years later, now recently, with a history of left upper and lower limb weakness associated with slurring of speech, which resolved in 15 minutes. Then we had done an MRI again. It has progressed now. The pictures of CADASIL now is typical of it. And he is again treated with dual antiplatelet statins, and this time with low molecular weight heparin. Maybe it was not indicated, but we had to give because he was getting recurrent strokes. 1 month later, again he presented with the third stroke. And this time his cognition has deteriorated. He had weakness again, and the hyperintensities were almost the same. He did not have any obstructive. He had little features of non-obstructive hydrocephalus with dilated ventricles. So this was a patient with recurrent cardiovascular, cerebrovascular events in young adult with CADASIL with recurrent strokes. So in recurrent strokes in CADASIL, patient will demonstrate progressive nature of the recurrent TAs and stroke despite treatment. Since we all know CADASIL will just progress despite any normal treatments with dual antiplatelets and statin. We just need to give him supportive care. Thank you. The reason of presenting these cases were that not all strokes are because of atherosclerosis. We need to find out other causes if the patient is young or if the patient presents with recurrent stroke. Actually, I started searching for these cases. I didn't have the report of one patient. She came to me when she was around 42-year-old with a stroke. I had thrombolized her, and she became better. We diagnosed her to have diabetes later. She is being treated for diabetes. Later, she had 2 other strokes. Then on seeing, I had actually missed the platelet count. Platelet count had been around 5 lakhs. Then going back to the previous platelet count, it was also around 5 to 6 lakhs. So probably then we worked out, we found that she had thrombocytosis. Then that patient is also on hydroxyurea. So after that patient only, I started searching for all these patients, and probably we need to give more importance to hematological and vasculitic causes of stroke so that we can prevent the recurrent strokes. Thank you.
Thank you, ma'am. It was an excellent presentation on evaluation of rare causes of stroke. Thank you. Now the floor is open for discussion.
Thank you, Dr. Aruna. It is a wonderful presentation. And the core concept that not all cases are atherosclerotic was well conveyed by your selection of cases. I have a problem with only the first case where you showed a lacunar infarct, and to call it a vasculitis simply based on the vessel wall imaging may be very difficult, as they say that all the atherosclerotic lesions also will show vessel wall imaging. Though they say atherosclerosis is more of an eccentric and non-homogeneous, whereas this is more concentric and homogeneous. The radiologists many times will struggle, and they say we are not able to decide between another, because if we never do vessel wall imaging in atherosclerotic diseases. Whenever we have suspicion of non-atherosclerotic, only we ask for vessel wall imaging. But if you do more and more, we find that in atherosclerotic cases also the vessel wall imaging is there. So that we have to probably wait and follow up the case to be sure. And I may not be going ahead and doing the treatment for a vascularic disorder based on that single
ANA
presentation alone. Another thing is I've seen such patients with the protein S deficiency. That is one deficiency which may not always be causing a venous stroke, and it's also well known to cause arterial strokes. I have a collection of few cases which isolated protein S deficiency producing arterial strokes. That's the first point. Second is the recurrent strokes, as you nicely pointed out, we had to look into all these etiologies, but in our setup, the most common cause of recurrent stroke is non-adherence to the antiplatelets. So what we have seen is when I ask the patient when they come back again, சக்கரை மாத்திரை அதெல்லாம் கரெக்டாக போட்டுக்கிறோம், ப்ரெஷர் மாத்திரை கரெக்டாக போட்டுக்கிறோம், இந்த ரத்தம் ஒரே அவருக்கு அது நல்லா ஆயிடுச்சு நிப்பாட்டிட்டோம். So all the patients think that antiplatelets are for the improvement of the current stroke, and they never got the concept of secondary prevention in their mind. So that is one major issue with our patients, where we need to counsel them at the time of discharge of the stroke that these medicines are not for your current deficit. These medicines are for secondary prevention. So they are all very well aware about the antihypertensives and the diabetic medications, but they are not aware of this. So most of them would have stopped. Again, the same problem of giving antiplatelets in the afternoon. So they will go back to their work and they say, எல்லா மெடிசன் நல்லா போடுங்க, மத்தியானம் போடுறது மட்டும் இடையில மிஸ் பண்ணுறேன். Irregular. So that's the reason why most of us have shifted it to the morning or night, the antiplatelets also. So that I feel.
Another thing is we are seeing probably clopidogrel resistance. Many patients who are already on dual antiplatelets for MI or some other things present to us with who are on regular antiplatelets present to us with stroke, or even our patients when they present to us with stroke, when we do an aggregability test, some of them, not many, like we do see clopidogrel resistance more than aspirin resistance.
That is well known. In our setup, clopidogrel resistance is more common, around 35%, and we don't have a very good way of checking for the aspirin. But I feel that most of the Indians are good responders to aspirin. So if they are on, so what they generally say is that if the patient is on clopidogrel and the patient develops a stroke, switch over to aspirin. But if the patient develops a stroke while on aspirin, then you look for the different mechanism of stroke. Probably they are, embolic stroke or some other mechanism, and that is how they say. Putting the patient on clopidogrel when he develops when he was on icosapent and develops a stroke is probably not correct in our scenario.
Probably we need to increase at least double the dose of aspirin.
And regarding this MTHFR gene, which you said, generally we look at the homocysteine. If it is more than 15, you look at the B12 levels. So B12 levels is what's called metabolic B12 deficiency is 400. So generally in all our reports it will be 196 and all. So less than 400 is considered to be metabolic B12 deficiency. So B12, if it's not there, we look for folic acid. If both of them are not there, then MTHFR gene may be indicated because it's a genetic cause of hyperhomocystinemia. That's how I know about
this
MTHFR.
Patient, because both the patients had normal B12 values, more than 700. That is the reason why we sent, and also had polycythemia. That was the reason when that we sent JAK2 mutation. So along with that, the reports were together. So we had sent MTHFR also.
Thank you.
We don't usually do a MTHFR, and it is not actually indicated to do. And there's no better treatment option. Anyhow, we'll be giving only folic acid supplementation.
Thank you, madam. Excellent presentation.
One comment. You told about the Cadacil, Notch 3 gene mutation. It's autosomal dominant inheritance. If possible, you can go into the family and check.
Sir, father died early, sir. Mother is alive. He has one sister. I've told her she is fine, sir. She is under our regular follow-up. They are the whole family. And I have told them to, if they are needed, to check for Notch 3 gene. But she says, I'm healthy, madam. I don't want to check for it.
Okay, thank you.
Thank you, ma'am, for the thought-provoking exploration of uncommon but pivotal stroke etiologies. As a token of our affection, may I request Dr. Subbaiah, Senior Consultant Neurologist, CSR Hospital, to hand over a small gift to the speaker and chairpersons.
We request the chairpersons to please come on stage.
Thank you all.
We will go for inaugural function, just about 10-20 minutes. After inauguration.
Now we have the formal inauguration of our SRH Stroke Symposium 2025, Basics and Advances in Stroke Management, conducted by Department of Neurology, Sri Ramakrishna Hospital and Genova. Ours is a QAI accredited advanced stroke center featuring cutting-edge technology and a skilled team of super specialists dedicated to deliver top quality care for stroke patients.
Now I request everyone to raise for the Tamil Thai Valtu as a mark of respect to our mother tongue and culture.
நீராலும் கடலொடுத்த நிலமடந்தை கெழிலொழுகும் சீராரும் வதனமென திகழ் பரத கண்டமிதில் தெற்கணமும் அதில் சிறந்த திராவிடனல் திருநாடும் தக்க சிறப்பிறை நுதலும் தரித்தனரும் திலகமுமே அத்திலக வாசனை போல் அனைத்துலகும் இன்பமுற எத்திசையும் புகழ் மணக்க இருந்த பெரும் தமிழனங்கே தமிழனங்கே உன் சீரிழமை திறம் வியந்து செயல் மறந்து வாழ்த்ததுமே வாழ்த்ததுமே வாழ்த்ததுமே.
Thank you, girls. As light signifies knowledge and wisdom, let us illuminate this occasion with the ceremonial lighting of the lamp. May I request all the dignitaries to kindly join.
Thank you all. May I request Dr. K. Ashokan, Chief Neurologist and Head, Department of Neurology, Sri Ramakrishna Hospital, to welcome this elite gathering.
Good morning to all of you. So it's my pride and pleasure to welcome you all for this August function. I extend my warm welcome to all of you. I welcome our Managing Trustee, Sri Sundar, our Joint Managing Trustee, Sri S. Narendran, and our Chief Guest and Guest Speaker, Professor Dr. Lakshmi Narasimhan, who is now President, Indian Academy of Neurology. He is Professor Director Sri Ramchandra Medical College Hospital, Chennai, and retired Director of Neurology, MIN, Madras Institute of Neurology, and he is Editor-Chief for Stroke Journal of India, and so many others. It runs into pages. I think that will be introduced at the time of his lecture. And I welcome our CEO, CAO, Medical Director, Medical Superintendent, and heads of all the departments, and other my colleagues, seniors, and my friends, all the PG students. So this sort of CME, what's the need for this CME? So as of now, we have 100 million stroke patients in the world, and out of which 10 million people are there in India with stroke. So 10% of the stroke burden is with us, the global burden, 10% of the global burden is with us. So it becomes very necessary, very important to identify the stroke and treat the stroke as early as possible so that we can give some good relief. So that needs some awareness. So you have to create awareness among public, among treating physicians. That's one important thing. Another thing, suppose if we could send the patient, identify the stroke and send it to the center, nearby center where the stroke facility is available, then it is possible for them to evaluate further, go ahead with thrombolysis and thrombectomy, which is a very important mode of treatment as of now. More than that, the prevention is better than cure. So we have to work up on the risk factors and other associated factors to prevent further strokes. And more than that, secondary prevention. After the initial treatment, the secondary prevention is becoming another important factor. Yeah, we have to go for that. So now that the initial assessment, evaluation, diagnosis and treatment. So all these things, nowadays we are also new. AI is coming into field, artificial intelligence. Okay, I don't say you go with AI for everything. It's not so. It's high-end, and maybe in certain situations might help. That's what you are going to hear from Professor Lakshmi Narasimhan today. And lastly, with all these things, if nothing doesn't work and the stroke is further increasing in size, massive, then we go for surgical decompression with our surgical colleagues. So all these aspects will be discussed today by our eminent speakers. Already we have heard from Dr. Veda and Dr. Aruna Devi, and some more we are going to hear from other expert speakers. So why all these things? Because all these things necessary to improve our knowledge. After all, knowledge is very important. By attending the CMCs, you gain knowledge. Knowledge imparts wisdom. Ultimately, knowledge and wisdom taken to bedside for the better patient care and patient treatment. So whatever knowledge you acquire, whatever wisdom you acquire, ultimately it's for the patient care. So that's why it becomes very necessary to attend all the CMEs, and we have to organize all the CMEs and enlighten you, and we have to enlighten ourselves. So with these few words, once again I welcome all of you for this symposium, stroke symposium, and get benefited. Thank you all, thank you.
Thank you, sir. As a token of our affection, may I request Dr. K. Ashokan to welcome our chief guest, Dr. Professor R. Lakshmi Narasimhan, with a bouquet. May I request Dr. K. Aruna Devi to welcome our Managing Trustee, Thiru R. Sundar, SNR Sons Charitable Trust, with a bouquet. Now, may I request Dr. Vedanayagam to welcome our Joint Managing Trustee, Thiru S. Narendran, SNR Sons Charitable Trust, with a bouquet.
Thank you all. It is an honor to have Thiru R. Sundar, Managing Trustee, SNR Sons Charitable Trust, with us. Sir brings enthusiastic leadership and a refreshing perspective to our organization with his consistent support and innovative approach. May I invite Sir for his address.
Very good morning to one and all present here today. It actually gives me immense pleasure to be here today for this continuing medical education program on neurology organized by Sri Ramakrishna Hospital. First of all, I would like to extend a warm welcome to all the eminent neurologists, neurosurgeons, interventional radiologists, and medical professionals who have gathered here to share knowledge and exchange ideas in this ever-evolving field of medicine. The human brain is one of nature's most intricate creations and a true marvel that governs every aspect of our being. Understanding its complexities, diagnosing its disorders, and offering effective treatments require not only scientific expertise but also compassion and collaboration. At Sri Ramakrishna Hospital, we have always believed in combining advanced technology with a human approach. And our neurology department stands as a true reflection of this philosophy. Over the years, our hospital has invested in the state-of-the-art neurodiagnostic facilities, advanced imaging technologies, and a highly skilled team of neurologists and neurosurgeons. Beyond infrastructure, it is our commitment to continuous learning that truly drives excellence. CME programs like this play a vital role in keeping our medical fraternity updated with latest advancements, treatment protocols, and innovative practices that can transform patient care. In the recent years, the incidence of neurological disorders such as stroke, epilepsy, dementia, and Parkinson's disease has been rising rapidly in India. This makes it all more essential for us to work collectively, not only in the treatment, but also in the early diagnosis, prevention, and rehabilitation. Our hospital's recent initiatives, including public awareness programs on stroke and early intervention for neuro emergencies and rehabilitation support, I think are in the right steps in the direction of neurodevelopment. At this juncture, I would like to place on record my heartfelt appreciation and gratitude to our esteemed team of neurologists, Dr. Ashokan, Dr. Vedanayagam, Dr. Aruna Devi, neurosurgeons, Dr. Murali, Dr. Vikram, Dr. Divya Palaniswamy, and interventional radiologist, Dr. Muthurajan, for their unwavering commitment, compassion, and clinical excellence. Their tireless effort is in patient care, emergency response, and academic contribution have made our department one of the most respected departments in our hospital and in Coimbatore. They continue to inspire confidence, hope, and healing in every life they touch, and we take immense pride in their dedication and hard work. Each and every CME adds a new layer of knowledge that ultimately benefits our community, and that, I believe, is the true spirit of healthcare. As we stand on the threshold of new discoveries in neurosciences, let us reaffirm our commitment to learning, innovation, and compassionate care. Together, we can continue to make meaningful differences in the lives of those who depend on us. Once again, I would like to take this opportunity to thank Dr. Lakshmi Narasimhan for being here with us today on the dais. Thank you, sir. Thank you for being with us. And I hope the CME is very useful for those who are attending it. And the presentation is of great usefulness to all of you. And for the development of this technology, I wish this CME a great success. God bless you all, and thank you.
Thank you, sir. It's my privilege to invite Thiru S. Narendran, Joint Managing Trustee, SNR Sons Charitable Trust, who truly believes that action speaks louder than words, for his address.
Good morning to all doctors. It gives me great pleasure to join you today for this continuing medical education program on neurology with theme Basics and Advances in Stroke Management, organized by Sri Ramakrishna Hospital along with Genova. I extend my warm greetings to all the distinguished doctors. CME programs like this are essential in fostering continuous learning expertise. We can ensure faster diagnosis, timely intervention, and better patient outcomes. I take this opportunity to appreciate the effort of all our doctors for their commitment in patient care and academic excellence. Your contribution truly reflects the vision and values of our institution. Thank you all.
Thank you, sir. We are extremely proud to have Dr. Professor R. Lakshmi Narasimhan with us today, a renowned neurologist. Sir is the President of Indian Academy of Neurology, currently serving as Professor and Head, Department of Neurology, Sri Ramachandra Medical College, Chennai. He was also the Director of Neurology, Madras Institute of Neurology. Doctor is also the Chief Editor of Journal of Stroke Medicine, and many more laurels to his credit. With this short introduction, may I invite Sir for his chief guest address.
Good morning, everybody. At the outset, I thank the Almighty for giving me this great honor and privilege to be among all of you. 1986, I was the house surgeon in Madurai Medical College, and Professor Ashokan sir was doing his DM neurology. We stayed in the same hostel, couple of rooms nearby. It was three of them, that great three trios were top neurologists in the country now. Professor Chandra, Professor Ashokan sir, and Tirunelveli, Professor Bhaskar sir. Sir? Ganeshan sir, and the Galaxy Hospital, Professor Ganeshan. And they were the disciples of the great Professor K. Srinivasan. And for house surgeons like us, it was an inspiration. The kind of academic discussions in the Department of Neurology of Madurai Medical College was so inspiring, with the two great assistants, Professor Jayakumar and Shivakumar, and Professor DRS, all of them were there, and that inspired me into neurology. So when I got neurology in 1991, April, I came to Ramakrishna to take his blessings in 1991, April. I came there and took his blessings before joining general medicine in Madurai Medical College. So my association of more than 40 years with him, I have seen him a very great person. Few people achieve things very silently. I always felt he is one of the unsung heroes in Indian neurology, and he deserves many, many more laurels in the country, and I sincerely pray for that. Second important thing about Professor Ashokan is technology you have to embrace. There's no other choice. Whether AI does AI would replace neurologists? It will not replace the neurophysicians or any doctor for that matter. But AI will replace the doctors who don't use AI. They will be replaced because it takes a lot of your mundane works in it and then saves a lot of your time. All of you know the most limited factor in life is time, and definitely AI would enable you to save your time in lot of ways. So in that way, not only in AI, in the stroke care, Ramakrishna Hospital, we all have a forum of things, and where the team of Professor Ashokan, Professor Aruna, Professor Vedanayagam, all the three, they share with us the tough cases in our academic forum. which made me jealous. The kind of work which they do here is tremendous and definitely requires a word of appreciation. I'm sure that this is the stroke care is at par with international standards. I would say a little higher up also, because abroad there are certain things which you cannot do. The things which are not indicated you cannot do. But here, at least with the consent of the patient, you can be more aggressive, and that's what they have shown. That cases where, in fact, a few of the cases are really, I was so impressed. And as a editor of Journal of Stroke Medicine, almost every issue I ask Dr. Vedanayagam to send, because they have their collection of cases is enormous. So whenever I fall short of an article or anything, almost every issue contains one of their articles. The STM, the Journal of Stroke Medicine, is it. Another thing, Coimbatore, there are two young neurologists who joined here, Professor Govindarajan's son and daughter-in-law, Shweta and Shakti. Shweta and Shakti, I will never forget them in my life, because on one day in the Institute of Neurology, the neuro-intensive care, there was a fire. Fire broke out. You could see the intensive care atmosphere is a very, very highly inflammable atmosphere. So many oxygen cylinders and everything. It was chaos and complete soot. The entire atmosphere was black, no visibility at all. So much of soot and all. 18 patients in the ICU, on ventilator. All my postgraduates, they took charge and evacuating them. The amount of commitment they showed is enormous, especially Shweta, which I have to mention, this has been talked in many forums also. One patient with a quadriparesis, it's a neurorespiratory intensive care, a patient with the GBS, quadriparesis, and he was the last patient to go. I told her, the fire was going there, the firefighters, everybody was there. She said, I will not leave until I get him out, because he's just holding my hand. So much of commitment, and ultimately with the ladders and all, we evacuated him, I was so fortunate that we could save every patient, with no patient died in the incident. And that's the greatest thing which all my students showed, and more than 15 of them are here in the city of Coimbatore. I'm very proud of all of them here, and my special mention to her. And in fact, you won't believe, we have to admit them, all my postgraduates, for carbon monoxide toxicity, and we had to give them oxygen. They saved every one of them. You could see the videos, and it was the first time when all the junk newses and all kinds of criticisms in the governmental setup, first time I felt the media congratulated all the doctors enormously and profusely for their commitment in that act. So I am very, very grateful to them. So Coimbatore is slowly becoming the health capital of Tamil Nadu. In fact, at least neurology health capital, I would say, because you can see that even in Parkinson's and other things, the focused ultrasound they led the country, the first pioneer to be done in Coimbatore. In stroke care, excellent progress has been made in not only in Ramakrishna, all the hospitals across. I'm so proud to see that neurology has grown in such a great heights in the city of Coimbatore. I'm fortunate that I am here to be with all of you. Wishing this function every success. Thank you so much for your attention.
Thank you, sir, for your words of wisdom. It's time to officially launch the Stroke Symposium on Basics and Advances in Stroke Management. We request our chief guest and dignitaries to join in the release of the foam board. Our heartfelt thanks to the dignitaries for their motivating presence and inspiring words. We'll now take a short tea break. We will be resuming with the next scientific sessions shortly.
லோட் பண்ணேன் ப்ரெசன்டேஷன் எங்கே லோட் பண்ணுங்க இதிலே பண்ணிடலாமா இதிலே பண்ணிடலாமா
My friends, this record comes to you through the sale
famous neurologists in India, he will be one among them. So I am so privileged that I did DM neurology with him. We were classmates for 3 full years. So if you really want to introduce Lakshmi, generally in all the meetings they say send one slide showing your highlights of your career. But this will go into 4 or 5 slides. So this will become a separate presentation by itself. So it's difficult to, bring out all his achievements in a, in a single, in 2-3 minutes. It's very difficult. So what I would rather do is to tell you all youngsters who are here what kind of a person Lakshmi is. There are so many things which characterize him, which I know personally. Only things which I know personally I'm going to talk. Is the sheer hard work. As Lakshmi was mentioning, the early 80s he was there in Madurai. So he had a lot of problem in the family. His father had CKD and the family was not very rich. So he had to necessarily work hard to get his money. So even then he used to take his dad to Chennai for renal transplant and was struggling to meet the expenses, and he used to go back to Pandruti and work hard and meet the expenses to treat his dad. And subsequently he lost the battle. And even afterwards when he joined for MD, after the MD he could have done the DM immediately, but for the financial constraints he had to continue his practice at Pandruti. And he has been really ambitious, and it's kind of ambition you should see. It's a kind of ambition which you can see in his eyes, that we all used to say. If Dr. Kaja, Dr. Sarala, the senior neurologists, if they were here, they would have agreed with what I am telling. So he has been highly ambitious throughout. Whenever you talk to him, his ambitions are sky high. I mean, he'll aim for the stars. He is such a kind of person, even during the DM days. And he was so passionate. There are some words which I want to stress here. So passionate towards the subject. And when we were doing our DM course, the ours was the first 3-year course. So we found a lot of shortcomings during our duties in the nights. We had to travel 1.5 kilometers towards the medicine ward and then see and write and come back. We will never have the follow-up of those cases. And as a group of 5 postgraduates, we realized the shortcomings of the DM course, which is run by the MGR University at that point of time. So this young Lakshmi at that time had already planned as the director what he will be doing to overcome these shortcomings which we all experienced. We were the first batch to go out to NIMS, Hyderabad. We went to NIMHANS and we had a very nice time together learning and exchanging various ideas. So the important word is the passion towards the subject. And after the DM, when he took up the director course, he totally changed. And I think some 2016, 17, at that time I went there. He totally changed the face of the Institute of Neurology. As he mentioned what happened in that critical care unit, he brought out the first time he introduced the neurocritical care, and he saw to it that all the patients from the neurologically afflicted patients from other departments are brought to the institute itself. There is no question of giving opinions. You have to take over those patients and manage. Then only your knowledge will improve. So our critical care, so we all had, I mean, he would have probably listed out our shortcomings. And for the subsequent batches, he saw to it that they don't suffer. So I was so, happy to see the kind of change he, as a single person, had done to the Institute of Neurology by improving the course curriculum of the DM neurology residents and bringing in the patients from all the neurology patients to the institute itself. We don't have to go to and we'll get the follow-up, we have good learning, and the neurologists are exposed to intensive care. I see 3-4 PGs sitting inside and managing those cases continuously. This is some kind of a change which is really phenomenal, and thanks to Lakshmi, this happened in the Institute of Neurology. And his mentoring capabilities, and then we have the living examples sitting inside the hall. The young neurologists, Arun Sivaraman, Kaushik, all were his postgraduates. How much he used to guide them, how much he used to, when we were students, what kind of exposure. We always used to discuss that. Only few of our teachers were like exposing us to the highest level of neurology. Some were only talking about American Academy of Neurology and the importance of being a member of AAN, attending the AAN conferences. So he was the one who kind of made sure that all of them do good research. And with this, and even last week when we had a recent conference, IAN conference, his students were talking to me about what kind of a mentoring he has done, and he has received a lot of awards from the AAN also. So being a mentor is a very important. It's not enough that you become a good neurologist and practice and take care of a few patients. How many good neurologists you are able to create in the country? And Dr. Lakshmi Narasimhan is at the forefront creating quality neurologists not only in Coimbatore, across Tamil Nadu, across South India, and maybe across India also. And his attachment to technology, that was very evident those days. He was the one who used to talk about PET during our presentations, and he used to get flack from senior neurologists. You talk first about clinical neurology, man, then you talk about PET. Now what is happening today? Today, last week itself, there was a case when I started the investigation with PET. So he used to, kind of look into the new technologies and embrace them. So he will be the ideal person to talk about the technology. And he used to be a computer wizard those days. And we were all very novice, and we never used to know. Even, getting an email account was very difficult at those times. We never knew more than sending emails. But he used to be a computer wizard those days itself. And another important thing is the communication skills. And suddenly one day, morning, myself and Kaja and Lakshmi were talking, and suddenly he picked up the phone and started talking to whom? Our examiner, Mahendrata. He is calling the examiner and talking, how are you, sir, and are you coming for the exam? So this kind of communication skills. And you meet a new person in any meeting. We see that within 2-3 weeks, he'll be sending mails, he'll be constantly interacting. This kind of a communication skill, we all used to lack at those times, and we used to kind of be jealous about Lakshmi for his, this is everything which I speak is absolute truth. Nothing is cooked up or made up. So what I'm trying to tell you is all these characters or all these things in one man. That is the hard work, the ambition, the passion for the subject, the mentoring capabilities and producing the next generation of neurologists, the embracing technology right from these early days of, doing medicine and being a computer whiz kid those days itself. I don't think there is any other person. I'm not telling you about his current position of IAN president. He's a World Headache Society president. He is the director of, former director of Institute of Neurology. All those things people have spoken about. This is something which I'm speaking from the heart of being a close associate of Dr. Lakshmi Narasimhan. So I don't think there is a better person, not even in Coimbatore or Tamil Nadu in India, to talk about AA in stroke, AA in a neurological subject. With this short introduction, I'm inviting Dr. Lakshmi for the subject.
I would like to add one more feather to his cap. He was my student in NK unit when I was a medical assistant in Madurai Medical College. I was a final year student, and he used to be very brilliant, and he was a giant at that time also.
In fact, thank you, sir. Thank you so much. Thank you so much, and I'm blessed. All the three people on the, as I said, two of them, Professor Subbaya sir in NK, Kasirajan sir unit was my assistant, and Professor under KS sir was a postgraduate. I was doing the house surgery under him. And Rajesh, out of his love and friendship for so many years, he has profusely praised me to the level of, when somebody, thank you so much. Thank you. This, I'm humbled by all these words. Thank you. And I'm going to, I just wanted to enjoy this.
My friends, this record comes to you through the Sales Talk Transcription Company Incorporated. Your speaker, the mechanical salesman. May I take the pleasure of introducing Mr. J. Willicombe Billows, the inventor of the Billows feeding machine,
movie,
a practical
where
device which automatically feeds your men
they
while
are trying the automation. Just have a look.
work. Don't stop for lunch. Be ahead of your competitor. The Billows feeding machine will eliminate the lunch hour, increase your production, and decrease your overhead. Allow us to point out some of the features of this wonderful machine. Its beautiful aerodynamic streamlined body, its smoothness of action made silent by our electroporous metal ball bearings. Let us acquaint you with
I'm just showing you.
Our automaton soup plate. It's compressed air blower. No breath necessary. No energy required to cool the soup. Notice the revolving plate with the automatic food pusher. Observe our countershaft double knee action corn feeder with its synchromesh transmission, which enables you to shift from high to low gear by the mere tip of the tongue. Then there is the hydro-compressed sterilized mouth wiper.
How to fast
Factors of control.
Anyway, the whole thing I just wanted you to enjoy. What is this? How to fast forward this? How to fast forward this clipping? கொஞ்சம் forward பண்ணு. Fast forward பண்ணு.
So on the shirt front.
இது வர மாட்டேங்குது. Thank you. I'll just wanted you to see this clip.
My friends, this record comes to you through the sales
It's not coming.
transcription company incorporated.
The whole
Your
thing I
speaker,
just
the
wanted
mechanical
to see.
salesman. May I take?
Fast forward பண்ணு பாரு.
Presentation view போயிருக்கு. அதனால நம்ம இதை மட்டும் இங்க வச்சே ப்ளே பண்ணிக்கலாம்.
இங்க வச்சு ஓகே.
ஸ்லைட் ஷோ போட வேண்டாம்.
இங்க வச்சு இங்க போடு.
அங்க இருந்து ப்ளே பட்டன். ஓகே.
Just see. This is how why I'm showing you this is the automation. They thought about it in 1932 is a film which is so even though the AI was there from almost nearly 70 years, AI is there. The transformation now only it has got the so everything has a boom. You know, .com had a boom, and every technology has a boom and reaches its peak. Now AI has reached its peak. What was fascinating is why this has come to a boom is because, you know, almost every walk in life now you have AI. There's nothing. I just thought I'll just ask a question to this. I asked, which is the best response you can see at the bottom a wife would expect from a husband? Yes or no? I just asked the ChatGPT, not the ChatGPT, the Sri. And it, after a lot of deliberations going this and it said the answer is, best response which the wife expects from the husband is, it said no. And I thought AI is not married. So what is important is, it is essentially a non-human intelligent agent. AI is nothing but a non-human intelligent agent. Why this it got complete appreciation is because the machine learning is the one subtype of AI where algorithms that allow computers to learn from examples without being explicitly programmed. For example, if you have a complex calculation, you can always break them into steps and then write a code for that. Whereas some assume that how to recognize your face, facial recognition by the brain. How will you code? Each one have certain, somebody will look at the demeanor, somebody look at the bridge of the nose, somebody look at the eyes, somebody look at the lips. And the identification of each brain has its own, the key features in the face which it remembers, and it's very, very difficult to write the program. So that is why it was not very successful. But now after this advent, it doesn't require any programming. Machine learning doesn't require any programming. Then subsequently, it is the deep learning came, which is there is an input, There are so many layers in that. The layers can be anything. For example, the eyes, the lips or the nose, or it can be the age or the sex, and whatever, all these inputs hidden in the layer, and then the output comes. Output, and the weightage, each one gives different weightages for each of the facial features. Similarly, this computer layers also gives weightages for different features and comes to a conclusion. And the output comes. So similarly, essentially like garbage in and garbage out only. But what is important is, if the garbage out is wrong, these networks are capable of learning. If the identified person is not Rajesh Shankar Iyer, it is some XY. If you say you're wrong, XY, next time it'll go back to the algorithm and learn, and then. So these are all reinforcement learning networks, and that is what made it's very successful. So coming back to my topic, A for diagnosis, A for stroke protocols, A for prognostication, treatment, rehabilitation, stroke surgery, and A for genomics, A for predicting stroke outcomes. Everything there is an A. And to my knowledge, stroke is the only field where most of the other field, it is still in the protocol stage. They have not done, a lot of things have not been, they have not calculated, they have not calibrated the AI, still in experimental use. The only system where partly epilepsy, but more or less fully in stroke, where the automation and the predictive things have come into the market for clinical use. So almost most of the cath labs, I asked Vedanayagam that you are using AI Rapid in your labs. AI Rapid you are using in the cath lab. That's what Vedanayagam told me in Ramakrishna. So almost everywhere there is a. So if you look at this is quite an interesting one. If you look at the human intelligence, what we do, multimodal, non-contrast CT angiography, perfusion, all these images we interpret. We also interpret the age, NIHS, risk factor identification, frailty examination patient. And all the same things can be done automated. All this can be automated. Automated interpretation of CT, automated interpretation of aspect scoring, E aspect, CT angiography, clot detection, LV, all these things can be done. And based on this automation, it gives a decision. There are two steps. One is automating the evaluation of all the investigations which you have. And then based on that, it gives a decision support. And also gives a prediction of what will be the outcome. But there are factors which are beyond that. For example, the patient's family status, patient's income, there are patient's affordability, what do you want, availability. For example, you may identify an LVO, but Vedanayagam would be there in an international conference for doing some work. So multiple other factors are also make the physicians to, even though the decisions might vary, but there are other factors which have to take into consideration, the finance, the outcome, and not only that, the family expectations also there. Whether they want to treat X and Y aggressively or not. All these things also matters. Those things AI has got us no role in all those things. So if you look at the AI-inspired methods can improve the quality of medical image, reconstruction algorithms on deep convoluted neural networks are utilized here. They denoise the MR brain perfusion images, arterial spin labeling, allowing diagnostic images to be created with very short scans. Multimodality CTA-based convolutional neural networks used for reduction of radiation. Now they have gone to the extent that total amount of radiation can also be minimized by rapid sequence acquisition. Look at the same thing. Based on the time, it can. What are the 4 things which you want from the imaging? Whether LVO is there, how much damage, what is the core, is there a penumbra, or is there M? These are the 5 things which we want out of the imaging. Any of the neurologists want only of these 5 things, and then based on that, you make a decision. And you have made the decision, what will be the patient will ask, sir, 100% poichiruvangala, sir. Every patient wants to know when he invests some money, whether he wants to know what is the outcome. And the outcome reasonably can be predicted by the AI prediction models to nearly about 70 to 80% specificity, which is slightly better than the. So the NIHS scoring system protocols are available. This is the one which is done in the European Association. And this is again, patient where you come with indeterminate time. Nobody has seen. Patient was found from a elder senior citizen home. Time not known. You go for how to identify the time of stroke is based on the DWA flare mismatch. And that is, the AI has wonderful algorithms to do that. And E-aspect score. All of you know that based on the first step in the ER, what you do is evaluation of NIHS, basic blood workup, refer to the plain non-contrast CT, do an aspects, and then decide whether how much of core and how much of the penumbra. So CT aspects is done by E-aspects. Algorithms used to present identify. This is the A-Viz, which is one of the good one, where it can pick up the LVO. 650 patients, this says evaluation of the diagnostic accuracy, 9 months trial using a Viz AI LVO algorithm on an LVO detection. It not only detects LVO, also looks at the collaterals. And A in large vessel occlusion, all more models detect the large vessel occlusion LVO using the non-contrast CT and CTA. Identify hypertense artery sign. The Huron LVO software reduces the time to thrombectomy by automating the LVO detection, and hence reframing the time with producing the surgery. All models can be used. The same thing was used in the DAWN, DIFFUSE, and all the 3 major trials, they use this only. This is the one. And then the hemorrhagic transformation. You are treating, you thrombolize the patient. You want to know how the hemorrhagic transformation, not only the hemorrhagic transformation, the prediction of the hemorrhagic transformation also. Quantifying the hemorrhagic transformation, all these things can be done by AI. Now they're using deep learning. The top 5 AI models we have given you, the iDoc, Avicenna AI, Brainomics, Rapid AI, and Viz AI. Here, the Rapid AI and Viz AI are the 2 most commonly used in the country. Half of them are using. The Brainomics is too costly for our country, but other things. But there are, in another couple of months I would say, not couple of months, 3-4 months, indigenous AI systems would be coming, which will be far, far cheaper than this. And the government, the government has created expanding the capacity building. They have created a capacity building in India, Department of Capacity Building for Artificial Intelligence. They have created a department, separate ministry and all. Huge funding is available to get data and put the data into as an open source for everyone to use so that they can develop AI algorithms. So India wants to become #1 in artificial intelligence, and already a lot of steps are being done for that. AI for prognostication, traditional prognostication basis modified ranking scale at 90, infarct volume, times, intervention, collaterals, all these things, and AI tools are available using forest plotting. And deep learning in the prediction of ischemic stroke thrombolysis functional outcome, a pilot study. Again, it is very good. AI for treatment. This is very interesting thing. This is called a Golden Bridge 2 trial in China, where one arm is treated by the conventional neurologist. The other arm is by AI-enabled. Every decision is AI-enabled. This is called a Cambridge 2 trial, randomized, cluster randomized, multifaceted intervention trial. What does it see? You see the result? Eligible participants with acute ischemic stroke, so standard care versus AI this support. They used the various algorithms called the SINA algorithm, which I don't want to. The results say that the AI-based clinical support system reduces the chances of new vascular event by 25.6% during the 3 months period. 3 months, patients treated by hospitals using AI support experience fewer vascular events compared to people receiving the standard post-care, and the treatment 2.9 to 3 versus 3.9. Statistically significant differences in physical disability levels between the patients in the AI-guided care and standard care. This is where the AI, this is one of the double-blind study where the AI proved slightly superior than our human intelligence. Then they said that no, we all have, the empathy factor will not be there, it's just a machine, it doesn't care for empathy. This is a double-blind control trial. A senior level physician would answer the question, and an AI emotionally driven, that most of the humanoids have now emotional embedded humanoids are there. Sophia is one of the first of its kind where emotion-enabled robo. That will answer the patient's frequently asked questions. Double-blind trial, which says patients do not know who is answering the call. And it is proved that empathy-wise, it is superior. The doctors group, the irritation was more and more questions we asked, they became irritable. And then they were blunt. All these responses were there. and it's statistically significantly superior in empathy. The humanoids proved to be superior than that. And A in endovascular thrombectomy, A in medical management is all, you'll see fairly, all AA-based systems can modify things. For want of time, I just don't want to. A in rehabilitation is very good. You know, Sarah said 16 million scale of stroke and 5 million live with disability. The data which we are missing is, so there are a lot of movement sensors, EEG readings, the patient tries to talk in the therapy sessions, all these things. There is enormous data is there. But we don't interpret, we just leave it. The patient tries to flicker when he's paralyzed, arms tries to move. All this they have connected to machines. And they have started looking at those data. That is, the data is not started reading between the micro movements, the intent and hesitations and hidden connections. The moment the brain loses billions of neurons, the body tries to rewire. A lot of things are happening in the brain. All those things produce certain micro movements in the paralyzed limb. All the data is enormous for any human person to interpret, and all these things where AI comes in rehabilitation. This is going to be the future, and these are all few, the Indian-based. Nirvana is one such thing where you can see it keeps, in virtual reality they will focus to reduce the circumduction gait in the gait training. You can see this is Eva Park. Aphasic patient, voice would have been better, so anyhow. She has to see and then give a commentary on all these things, and that produces a lot of biofeedback, and you can see how she enjoys that. These are all available in our country. This is purely Chennai, the Mumbai IIT based thing for virtual reality of using this bubble top for the upper limb rehabilitation. This is the balancing it, and this one, catch the scoop. All these programs are being done, and this is the matching the square. And there's one more. They have developed these IIT. Madras also have developed a virtual cyber hand, and this is Mumbai one, which costs about 4 lakhs. A cyber hand which would, with all the haptics embedded in it. The first time I was amazed that the technology, haptic technology, where you wear the hand and whatever is felt on the other hand, you will feel it. This was originally used in porn. Most of the porn films, they send you a cyber glove, haptic glove, which I don't know whether 2003 I wrote an article on virtual reality in neurology, which was published in the IAN reviews. At the time I thought now it's all true. Now it has been taken into telemedicine. Most of the telecontrol, all the ICUs, night duty is done in Mohaper and Chennai. All the ICUs. The duties, also board certified neurologists will go there. Whatever palpation, they use a cyber hand and then the cyber glove and then palpate. The other side, the same cyber glove is worn by the nurse. She will palpate the abdomen. The same thing, whatever she feels will be transmitted onto this end using the cyber glove. So the telemedicine has evolved into such a big level. So this is the virtual reality. You can see the sensors on the patient, where the patient is walking. All these things are available in India. So it is not humans versus machines. It's not a contest. It's only a collaboration. So what we are creating is not machines that think like us, but systems that help us to care better. Not algorithms that replace judgment, but tools that helps to decide better. Not technology that distances, but intelligence that helps to heal better. Genomics, as there was an article by Professor Aruna was telling about this, the entire genomic data AI will pull out the data and tell that don't prescribe clopidogrel. He's got CYP19 positive, is a rapid metabolizer, no question of all these things. The entire genomic data AI will pull and tell you. Like not only clopidogrel, for example, in newer anticoagulants, these CES1 polymorphisms, which are contraindicated, it will give a prompt. No, is CES1 positive, don't prescribe dabigatran. It will say and make your prescription wiser. In the same thing, thrombolysis, don't use, it's got one Willebrand, one gene defective, you will profuse. So in a sense, it will produce all this areas where AI has already come in this. So This is a bridge and this is a wall. Both have the same bricks. What is important is making the wise choice. Similarly, technology can make or break one. I just want you to leave you with the thought to profound. Have this clipping. This is a famous iRobo from Will Smith. The truck smashed our cars together.
Pushed us into the river.
The voice would have been better. Can you have the voice?
Pretty pliable at those speeds. She's paying, I'm paying, the water's coming in. I'm a cop, so.
They were both of them. They're drowned in the
I
car.
already know
One
everybody's
girl
dead.
and this man.
Just a few more minutes before we figure it out. And as Ford was passing by, saw the accident and jumped in the water.
S4 is a robo.
You are in danger.
Save her! Save the girl!
Save her!
He's trying to save the girl. He's asking the robot to save the girl, 11-year-old girl. It didn't save her.
But it didn't. Save me.
It saved him instead.
The robot's brain is a difference engine. It's reading vital signs. It must have calculated that.
It did. I was the logical choice. Calculated that I had a 45% chance of survival. Sarah only had an 11% chance. That was somebody's baby. 11% is more than enough. A human being would have known that. Robots, nothing here, just lights and clockwork. Go ahead and you trust them if you want to.
Thank you. I will leave you with this thought. Thank you so much for your attention. So we are definitely superior. We have a lot of things, and this is one such example of what is happening. Thank you.
Thank
Any
you.
questions I'm ready to take.
Thank you, Dr. Lakshmi. It's a wonderful presentation.
No.
And at the end of the presentation, it's nice to know that the machines are having more empathy than human beings. So all of us would like to have one machine at home to reply to our wives' questions. So, and second thing is, even we were 10, 15 years ago, Vishwanathan Anand and Anatoly Karpov, they were all beaten by the chess computer. So things were happening, and when you feed all the moves into the system, they produce better moves than what the human mind can do at that point of time. So we knew that the things are coming this way. One question to you is, what do you foresee in the next 10 or 20 years about the role of a neurologist? Do you really think that there is some kind of a threat for us?
No.
So what will be the younger generation doing as a neurologist with the so much advancement of
No, not
AI?
at all. The hospitals will be blessed with, the initial front office will be done by robo. The robo will collect all the demographic data, and another robo will guide them to the doctor. Doctor will do the clinical examination and order for all the, collecting the order, going to various parts and getting this. And doctor will get the genomic data of this, fill in, analyze, and what are the comorbids, what are the drugs, all these things will be done. And finally, the prescription will be given by the doctor. And once the doctor finishes his prescription, it will be screened by the AA again and tell that it's fairly a decent prescription and pass it on to the counseling about the prediction. AA, one humanoid with empathy, high degree of X as recent bereavement in the family, empathy factor 8. The doctor will write empathy factor 8. It will go to the humanoid with empathy factor 8 and it will say, I know that you have got a recent bereavement in the family. It is unfortunate that you had this disease. And we are trying to do all this in a most gullible voice, the humanoid robot. This is what is going to be a future. We have to, but we will never be replaced.
Recently,
I'm sure about that.
in a conference in Prague, when we were eating in the hotel, the entire food was served by the robot. It was bringing the food on a table. It was bringing
even in Chennai, the ER, most of the reports are collected by robot only. They go to the lab and collect all the reports and bring it to the ER. The Apollo had introduced it long back, about 4 or 5 years back. and the dossier comes and gets handed over to the patient. These things are going to be one, and even in the theater as early as 2003, sir, in Shizuoka, in the theater there were robots which would collect the soiled things. Before the surgery, they feed 12 towels. Unless 12 towels are you put the 12 towels into that, it will not stop. One towel is missing, the robot will keep shouting before the closure. So these are all very, very small task-specific robots will keep doing. Already now, we have the robot to clean the house, all these things. These are all going to be the future. You have to adapt to the technology. The earlier you adapt, the better you are.
But there is a real threat to the job in terms of, for example, the radiologists. This is the one group which has been affected even in as you said, in the night duty, the CT scans are all reported by the AI and not the radiologists. So I think there is a drop in the job opportunity for radiologists, which has been highlighted in various Western thing, and as well as in India also. So is it going to kind of, this is a concern for all the doctors?
Yeah, I understand. But one thing, like alcohol, the AI also hallucinates. So as long as it hallucinates, our job is not under threat. Second thing is the legality. If the entire thing is done by an AI, report is done by AI, if I make a decision based on AI, who is responsible? Who is responsible for the decision? The report is done by AI. AI says it is a large vessel occlusion, and to his surprise, when Vedanayagam goes in and finds there is no large vessel obstruction, and he closes and comes back and says that nothing was there. And who is the culprit? Who has to blame? The legalities have not evolved so far. A lot of things have to be done, long way to go. At least as long as we are alive, I don't think we are safe. For our generation, we are safe. Thank you. Thank you, sir. Thank you so much.
Thank you, sir, for a forward-looking presentation on AI's transformative role in neurology. As a token of our appreciation, may I request Dr. Lakshmi Narayanan, Senior Consultant Neurologist, to hand over the gift to our speaker and chairpersons.
Thank you all. Advancing further, our next session covers endovascular treatment of acute ischemic stroke. Our renowned speaker for this session is Dr. K. Ashogan, Chief Neurologist and HOD, Department of Neurology, Sri Ramakrishna Hospital, Coimbatore. The chairpersons for this session are Dr. P. Bhaskar, Senior Consultant Neurologist, KMCH, Dr. C. Christopher Mariadas, Senior Neurologist, St. Lucas Hospital, and Dr. V. Sadish Kumar, Senior Consultant Neurologist, KGM Hospital.
Yeah, thank you. Thank you for calling me. So my topic is going to be on endovascular treatment of acute ischemic stroke. This we are doing along with Dr. Muthuraj, our interventional radiologist. Muthuraj, are you there? Okay. So, by treating stroke, there are three main principles in acute stroke care. That is, achieve timely recanalization of the occluded artery and reperfusion of the ischemic tissue, number one. Number two, optimize the collateral flow. And number three, avoid secondary brain injury. There are three zones of injury that may occur following LVO, already told by Dr. Vedanayagam. One is ischemic zone, that is central core, which is irreversibly injured. Around surrounding that is ischemic penumbra, this is ischemic but still viable cerebral tissue. That's the area we are striking with. Then benign oligemic zone, that is the third zone that does not place the tissue at risk. Ischemic penumbra. The ischemic penumbra is an area of brain tissue that is viable but is critically hypoperfused and will progress to infarct in the absence of timely reperfusion. Timely reperfusion therapy is the most effective maneuver for salvaging ischemic brain tissue. Thrombolysis within the window period of 4.5 hours, everyone talks about that. But if it is beyond 4.5 hours, what are you going to do? That is mechanical thrombectomy. Here the window period is 6 hours, but you can have extended window for late presenting strokes up to 24 hours, 24 hours, sorry. Collateral circulation. Primary collaterals refers to circle of Willis, that is anterior communicating artery and posterior communicating artery. Secondary collaterals refers to ophthalmic artery and leptomeningeal arteries. Tertiary collaterals refers to newly developed vessels through angiogenesis. DSA, digital subtraction angiography, is a gold standard to evaluate collateral anatomy. IV thrombolysis and endovascular therapy. IVT is the standard of care for eligible patients but has treatment limitations. Short time window, as I told you, is only 4.5 hours. Now, of course, we are expanding. That's a different issue. But as of now, 4.5 hours. And patients with increased bleeding risk, of course, you can't go for thrombolysis. Proximal artery occlusion and large vessel occlusion causing large clots. These large clots cannot be lysed with your thrombolysis. Hence, these patients should be considered for EVT because they are more disabling. So, mechanical thrombectomy is the choice. What's that? Mechanical thrombectomy is a cutting edge, minimally invasive procedure for treating acute ischemic strokes caused by large vessel occlusions. It involves using specialized equipment, including a stent retriever, a small lead-like device, to physically remove the clot from the affected artery. Mechanical thrombectomy candidates for acute endovascular stroke therapy, people aged 18 and above. NIHSS score is 6 and above. So I think most of us, all of you should know about NIHSS, National Institute of Health Stroke Scale. This is the score 0 to 42. Rather, this we evaluate by neurological examination, assessing consciousness, eye field examination, language, speech, motor sensory functions, like 11-point score. 11 things are performed and 42-point score. 0 score is no stroke, 1 to 4 mild stroke, 4 to 14 moderate stroke, 15 to 20 moderately severe stroke, above 21 up to 42 severe stroke. So time from symptom onset to groin puncture less than 6 hours if evidence of sizable ischemic penumbra is seen on perfusion imaging. And presence of LVO. And diffusion weighted MRI showing core volume less than 50 ml according to Don's criteria and core volume less than 70 ml according to diffuse criteria. What are the contraindications for thrombectomy? Intracranial hemorrhage, of course we don't do. Large infarct core with minimal penumbra. See, core is large but penumbra is small. We don't do thrombectomy. It should be core is to penumbra 1:1.5. One portion is core, 1.5 portion is penumbra. Ideal case for thrombectomy. Then small vessel occlusion we don't do, and coagulopathies that cannot be corrected. An elevated BP more than 180, 110 that cannot be corrected with the drugs. Because reperfusion, hemorrhage. Trials in EVT and mechanical thrombectomy, most of the trials for anterior circulation strokes only. Mr. Clean, Revascat, Escape, Swift, Extend, and Thrash. Thrash randomized patients up to 4.5 hours from symptom onset, but higher rates of good outcome in Swift Prime and Extend IA trials in the classical window of 6 hours from symptom onset. Escape and Revascat proved benefit of mechanical thrombectomy for patients with anterior circulation strokes up to 8 hours of symptom onset. ESCAPE trial also randomized patients up to 12 hours of symptom onset with reasonable outcome. So if you look at this window we had started with 4.5 hours, went up to 6 hours, 8 hours, then 12 hours, but still we are expanding the window. How? The concept of tissue window versus time window has proved useful for selecting patients for mechanical thrombectomy up to 24 hours from symptom onset. This includes wake-up strokes and strokes of unknown time of onset. Dawn and diffuse criteria, these two clinical trials showed excellent clinical outcome in patients treated with up to 24 hours from symptom onset. Endovascular therapy in acute ischemic stroke. See, we do the endovascular treatment only for large vessel occlusions. What are they? We talk about ICA, internal carotid artery, MCA, middle cerebral artery. In MCA also only M1. MCA has got 4 segments, M1, M2, M3, M4. M1 is sphenoidal, M2 is insular, M3 is opercular, and M4 is cortical. We are striking only the M1 as of now, and probably with little difficulty we go up to M2. M3, M4 we don't attempt to lyse. So ICA, M1, MCA, and in the posterior circulation basilar artery. Only these 3 vessels we target for mechanical thrombectomy. For example, if a patient has got MCA stroke because of the M3 or M4 occlusion, we don't. Video வர மாட்டேங்குது. Video வர மாட்டேங்குது. This is the problem. அப்போ ஏன் பென்ட்ரைவே போட்டுக்கலாமா? வீடியோ வர மாட்டேங்குது. திருப்பி கேட்டிருந்தாங்க. சரி, என்ன நெக்ஸ்ட் அது வருதா பாருங்க. இல்லை அதர்வைஸ் என் பென்ட்ரைவ் யூஸ் பண்ணலாம் இல்லையா? எங்கே இருக்கு? வராதான். சரி, முன்னமே சொல்லிக்கலாம். சாரி. ஆமாம். சரி, ஓகே. அங்கே அதில் ப்ளே பண்ண முடியலையா? சரி, ஒரு நிமிஷம். அதிலும் ப்ளே ஆகல. சரி, அந்த லேப்டாப் கொடுங்கப்பா. இல்லை ஏப்பா அங்கே ப்ளே பண்ணி பார்த்தேன்னு வந்தது. எடப்போ அங்கப்பா What is it? Self-expanding stent is passed through the clot is retrieved and stent is removed along with the clot. That's how it's done. அடுத்து வர மாட்டேங்குது. Slides. Zero வாங்குறீங்கப்பா. இதுக்கு அடுத்த slide. Atherosclerotic disease or calcified wall, adherent thrombi, or dissection of the vessel, difficult vascular access, very tortuous vessel, very difficult to access. Formation of distal emboli. As you are removing the clot, you tend to get distal emboli. This thrombectomy is declared failed if no recanalization after 3 passes. First pass, you get something. Second pass, you get something. Third pass, still it is reocclusion. Then you call it as failed thrombectomy. After intracranial stenting, the acute intracranial stenting is a promising bailout. So this stenting, what I am going to talk is it's a bailout procedure. It's not a routine procedure. After thrombectomy is failed, then we go for stenting. So case 1, the 46-year-old male admitted with the sudden onset left hemiparesis, slurred speech and left EM and facial palsy, presented 9 hours after stroke onset, 9 hours, that is out of window period. So known hypertensive on treatment, alcoholic smoker, BP 140/90, NIHSS 7, so it's a mild stroke, and core volume 35 ml. He is the patient with left hemiparesis, and that is the DW showing large infarct on the right MCA. So that is M1 occlusion and MR angiogram, right side. So he was taken for primary direct thrombectomy, and DSA shows again M1 occlusion. And these are the clots retrieved from the M1 MCA. And after clot retrieval, look at this, very good recanalization of the vessel as well as revascularization. You should achieve both recanalization and revascularization. Opening up of the vessel is recanalization, perfusion is revascularization. Both we could achieve. So after just 5 days after the stroke, after the thrombectomy, we could make him walk. Improved well, we could make him walk and discharge. The second case is again large vessel occlusion, right M1 occlusion, thrombectomy, angioplasty and stenting done. As I told you already, here we tried thrombectomy, didn't open, reocclusion, we tried angioplasty, the ballooning, opening of the vessel, didn't work, then we had to go for stenting. 48-year-old female admitted with sudden onset giddiness, left upper and lower limb weakness and slurred speech since 8 hours. Known diabetic on treatment, not a hypertensive, RBS 160, BP normal, CT brain done outside showed hyperdense MCA sign. That is, she came with the CT done outside, which showed hyperdense MCA sign. Here what we did, DSA straight away showed right M1 MCA occlusion, embo trap was placed and a small clot was retrieved. Post-procedure injection showed significant 99% stenosis distal M1. Repeat check angio after 5 minutes showed reocclusion of M1 MCA, so we had to go for angioplasty done. Again check injection after 10 minutes after the angioplasty, reocclusion of MCA. Hence MCA was stented, no other go, this is a bailout procedure, stented. Post-stenting injection showed good forward flow in MCA and its branches. Lady with left hemiparesis, So this is what I mean, dense MCA sign, just plain CT scan, nothing else. Plain CT is showing dense MCA with left hemiplegia. Okay, that's a sign of thrombus in the MCA. And DSA showed M1 occlusion, embo trap placed, clots retrieved, but if you look at this, there is still some narrowing is persistent. See, re-occluded. After that, embo trap, clots removed, slight narrowing, but again re-occlusion, nothing is seen. So now angioplasty, again the occlusion is persisting, narrowing, look at this. So we have to go for opened up, good recanalization as well as revascularization. You can call this revascularization or So 8 days after thrombectomy, we could make her walk with support. Look at this, with little support, she is walking. 25 days after thrombectomy, she is walking without any support. She is almost normal. So case 3, the 55-year-old male admitted with the right upper limb and lower limb weakness since 4 hours. 4 hours. So 4 hours means very much within the window period for thrombolysis. Known hypertensive on treatment, BP 140/90, conscious aphasic, conscious aphasic, right hemiplegia. So that is the left MCA infarct, large infarct. MRI DW showing large infarct in the left MCA. And if you look at this is a poor angiogram, MR angiogram. See, just comparison, this is called right ICA, that is right MCA. But what is there? Left side is not seen. ICA is not seen, there is no MCA. So ICA, MCA, total occlusion, but within the window period. So here what we have decided, of course, since it is within the window period, we lyse. But with lyse itself, the clots are not going to be retrieved completely or resolved completely. So we plan for bridging therapy. So first, again CT, see dense MCA. There is a thrombus in MCA also along with ICA. And look at this complete occlusion of the ICA. That is CT angio. You can see beautifully. ICA is totally occluded here. No ICA at all. Presented within 4 hours of stroke onset, so he was given IV tenecteplase. Then later bridged with thrombectomy. I mean, taken up for mechanical thrombectomy within 30 minutes after bridging with IVT. So in the angio suite, so patient is thrombolized, taken to angio suite, but what's happening? Still it's there. It's totally blocked ICA. Nothing is there. Your thrombolysis didn't work up there. So these were the clots retrieved after mechanical thrombectomy from the ICA. And ICA now it's opening up. Previously could not see anything, now it's DSA, it's opening up ICA. But MCA still blocked. Further clot removal, MCA is opening up. MCA is opening up. So nicely, good recanalization as well as reperfusion. And just 1 week after the stroke, we could make him would have gone for craniectomy, etc. So next case, here the carotid angioplasty and the mechanical thrombectomy, angioplasty and stenting for 99% stenosis of proximal ICA and MCA occlusion. 55-year-old male admitted with sudden onset of slurring of switch, blurring of vision since 11 hours. 11 hours out of window period. Left hemiparesis, dysarthria, left UMN facial weakness, known diabetic hypertension treatment, RBS 280, BP 140/80, NIHSS 16. 16 means moderate stroke, or you can say moderate to severe stroke. He is the patient with left hemiparesis, MRI brain with angio revealed acute infarct right fronto-parieto-temporal lobe involving insula and basal ganglia. No flow signal in the right MCA, reduced to a right ICA. So this in fact right MCA, frontoparietal, temporal and insula. That is flare. Flare still it has not set up. And MR angio, so MCA is totally absent. ICA, this is ICA. It's there but narrowed, not clearly filling up. MCA is absent. And this is because why ICA is not filling up? Stenosis, look at this. 99% stenosis at the origin. And after the clot removal, it's opening up. And MCA, after the clot removal, good recanalization and revascularization. And angioplasty was done for that stenosis, 99% stenosis, angioplasty, balloon, and later stenting. So after the stenting, it's now completely opened up, good revascularization. And these are the clots removed from MCA mainly, ICA extremely stenosis, MCA clots. And we could make him walk with the support, with lots of support after 7 days. And after 30 days of thrombectomy, of course, we could make him walk without support. Of course, walking with the limp, but without support. So these are all anterior circulations. 5 minutes I'll finish up. We'll go to the basilar artery, posterior circulation. As I told you, ICA and MCA in the anterior circulation, basilar artery in the posterior circulation. Basilar artery is the neurologist's equivalent to cardiologist's left main coronary artery. A cardiologist, if he happens to see a patient with left main coronary, he jumps, shouts. Likewise, if you happen to see a patient with the basilar artery occlusion, you have to jump and do something, intervene. Otherwise, you are going to lose the patient. So, occlusion of either artery can be fatal without rapid reperfusion. So, mind you, the attention and BIOC trials, these are the 2 trials which were published or presented in European Stroke Organization in May 2022. May 2022, not very far off, 22 only, just 3 years. Till 3 years back, we are not very confident of doing basilar artery occlusions because there was a basic study, best study. These studies were telling basilar artery occlusion, medical management is as good as thrombectomy. You need not go for thrombectomy. You will lose more harm to the patient by doing thrombectomy, confined with the basilar, medical management. In the sense, thrombolysis, aspirin, etc. But 2022, the Chinese, both the Chinese trials, these trials proved beyond doubt, there are a select group of patients who definitely benefit from thrombectomy in the basilar artery. So, this case 5, 25-year-old male admitted with sudden onset weakness of left arm and leg and slurring of speech since 18 hours. Imagine, since 18 hours. He is presenting to us with stroke and no comorbidities, BP 130/80. MRI brain, acute infarcts in the left thalamus, right midbrain and bilateral cerebellum. Severely narrowed or occluded distal right vertebral artery, distal basilar artery and bilateral superior cerebellar artery. If you look at this, the posterior circulation, everywhere the infarcts are there. These are the cerebellar infarcts, bilateral cerebellar infarcts. That is the left thalamic infarct. That is the right midbrain infarct. Cerebellum, thalamus, midbrain. After the structures in the posterior circulation, both the cerebral hemispheres, both thalami, and your brainstem, pons and midbrain, and of course, thalamo-geniculate vessel supplies the thalamus. These are the structures in the posterior circulation. Almost all the structures are affected. So, MR angiogram showed basilar artery top occlusion. DSA confirmed basilar top occlusion and he was taken up for primary thrombectomy. Why do you say primary thrombectomy? Of course, we could not do thrombolysis, 18 hours already, so direct thrombectomy. Look at this DSA. This is what I am telling. This is the basilar artery, but what's happening? Distally it is occluded. Nothing is there. You can't make out PCAs or superior cerebellar arteries. Nothing is. These were the clots removed from the basilar top. Basilar top. So now look at this. Whole thing is recanalized. Basilar artery is very well visualized, recanalized. And your PCAs, posterior cerebellar arteries, very well seen. Superior cerebellar arteries all opened up. So just 3 days after thrombectomy, we could make him on command. He's trying to lift the left hand. He came with the left hemiplegia. So 1 week after thrombectomy, he is a little more stabilized. Now he is lifting up with support, left hand. But still he is on Rayleigh tube. Why Rayleigh tube? Naturally. Any brainstem stroke, you get bulbar palsy, difficulty in swallowing. So Rayleigh tube is there. Dysarthria, dysphagia, dysphonia, all will be there in basilar stroke. That is 14 days after thrombectomy, little more stabilized. We could make him stand with support. Rayleigh tube is now removed. At this juncture, he is able to take orally. So 45 days after thrombectomy, when he came for the first review, look at the quality of improvement. He is walking without support, with limping, of course, without support. There is basilar artery occlusion. Probably this is the last case. This is thrombectomy with angioplasty. So previously we did only thrombectomy, he recovered. But here, thrombectomy, he didn't recover, we had to go for angioplasty. This 50-year-old male admitted with sudden onset giddiness, slurred speech and left hemiplegia since 12 hours. 12 hours, again out of endo period. Hypertensive and irregular treatment, BP 160/100, chronic smoker, alcoholic. MR-DW showed right pontine infarct. MRA showed basal artery occlusion. Total, proximal and distal. Taken for direct thrombectomy, clots retrieved from the distal basal artery. Proximal basal artery showed tight stenosis, 99%, for which angioplasty was done. 50% opening achieved with reasonable flow, so stenting not done. 7 days after thrombectomy, you could make the patient walk. So, look at this. You can easily make out large right pontine infarct. Just here I would like to mention one thing. When I was doing MD general medicine, when we go for the exam, there was one famous examiner, I don't want to mention the name, he used to ask the candidate, what's the prognosis in pontine infarct? So those days it was felt, pontine infarct, 99% mortality. Okay. So that's the question used to be. If the examiner happens to ask you what's the prognosis in pontine infarct, you are out. So such a large infarct in the pons, but now the things have changed, it's not so. So that's MR angio. You can make out the ICS, both ICS, but basilar. Posterior circulation is not visualized. There is no basilar artery, no PCS. That is the DSA. See, again you can make out vertebral artery, but basilar artery is not seen. Only faint, this thing is here, but otherwise it not seen. Basilar artery totally occluded. So clots, stent placed in situ, clots retrieved from the basilar artery. These are clots retrieved from the basilar artery. After the clot retrieval, what happens? See, distally it's opening up. Good recanalization, but proximally at the origin still, look at this, 99% narrowing. Okay, so like a thread-like basilar artery proximally. After angioplasty, ballooning, it's opening up. But with this opening itself, there is a good forward flow. Basilar artery is very well made out, as well as PCS and the superior cerebral arteries. So with that we stopped. We didn't go for stenting because we improved with this. And 2 days after thrombectomy, he is trying to move the left arm on command. And 4 days after thrombectomy, we could make him sit up in the chair. Again, he is on Rayleigh tube because of the bulbar palsy. 7 days after thrombectomy, we could make him stand with support. Still, he is on Rayleigh tube. Dysarthria, dysphagia, all those things. And 14 days after thrombectomy, we could make him walk with the support, but your Rayleigh tube is out now. There is no Rayleigh tube. He was taking orally at this time. And 45 days after thrombectomy, look at the nature of improvement. So he almost recovered totally. That's what we go for MRS scoring, modified Rankin scale, the scoring. The MRS is for assessment of the improvement. Because I don't want to go into detail of the MRS, no time for that. And conclusion, mechanical thrombectomy markedly improves the outcomes of patients with a stroke due to large vessel occlusion. LVO strokes presenting within the window period of thrombolysis, we do bridging therapy and sometimes direct thrombectomy. Strokes presenting out of window period for thrombolysis and late presenting strokes, we have the option of mechanical thrombectomy to revascularize the ischemic tissue. If no recanalization or revascularization after thrombectomy, that's called failed thrombectomy, we do angioplasty and stenting. So angioplasty and stenting done as a rescue procedure, as a bailout procedure, if you are not achieving the good recanalization. It's called a TC, a small thing about TC. TC means thrombolysis in cerebral infarction score. That score measures the flow, forward flow in the arterial system. If there is, and TC means it rather measures the flow after thrombectomy in the artery. So 0 to 3. 0 means there is no flow beyond the clot. The clot is there in the artery, no flow beyond the clot. 1 means there is trickle of dye beyond the clot. 2, partial recanalization. 2 also, 2A and 2B. 2A, revascularization but less than 50% in the vascular territory. 2B means more than 50% near normal but not complete revascularization. 3 means complete revascularization. Okay. Likewise, if you get to 2B and above, that's a good outcome. If your revascularization is less than 2B, then you have to revise and go for angioplasty and stenting after thrombectomy. So with these treatment options, schedules, there is a paradigm shift in acute stroke treatment. And definitely, patients are helped with this. Thank you. Thank you.
Thank you, Ashokan. It was fantastic, and I think nobody has slept. He has done very well. So initially, some 2 or 3 years back, somebody asked, who are the people forming the stroke team? We usually say neurologist, neurosurgeon, physiotherapist, and occupational therapy. But it has changed. It has changed. After 3 years, now we have the best person into the stroke unit is the interventional radiologist. And the interventional radiologist is forming the main person in the stroke team. As you said, the whole thing is done by the interventional radiologist. Still we neurologists, very few neurologists are doing the interventional workup. And the amount of physiology they understood to make all these things work, we feel one of the best arm the neurologist has got is the interventional radiologist. Because you have a patient with right hemiplegia, you make a MRI, he has got a right MCA territory block, M1 block, and you know this IV thrombolysis is not going to work. And if you don't do anything else, he is going to have a whole MCA territory infarction, then you will end up with decompression surgery. That scenario has been changed only when we get this new person, interventional radiologist, coming to the picture and doing the thing, just opened it, and the amount of infarction which is going to happen has been reduced to the 4, and the number of decompression surgery has come down drastically after this one. So this is a very important part, and the best person who is now in this stroke unit is the interventional radiologist, and that's one of the reasons a lot of people doing MD radiology, after MD radiology, they are coming for fellowship in stroke therapy, interventional radiology. And you can see people with 0 by power, after they do the endoctomy, the flow comes and they do a very good work. Nothing we can do anything about this. You have to depend on them. As you said, that's the limitation line. For example, as you said, if you have a M1 occlusion, you can do a thrombectomy. If you have a M2, M3, M4, you can't do thrombectomy, it will not work. You are going to end up with more harm rather than
Mike, not talking. Mike.
Hello.
Yes, yes.
No, the interventional radiologist has come to our help. Still, as he said, if there is an M1 occlusion, you do a thrombectomy, the result is going to be very good. If there is an M2, M3, we don't attempt because the mortality and the morbidity attempting M2, M3 is more rather than leaving that one. That's the only place where still people are doing, whether we can go for an intra-arterial tenectoplase. That's the second one, M2, M3, M4. If you are not able to go there, we go for an intra-arterial tenectoplase. That's the next thing which is going on, which is also giving some relief. But all these intra-arterial tenectoplase has been done in China. We have not done it in Asia. Okay. That's a very good. So if there is any questions, you have got Ashokan the stage to answer.
Dr. Ashokan, what is bridging therapy? What do you bridge?
No, no. Bridging therapy is rather first doing lysis, then later go for thrombectomy. You do the bridging with the lysis, then thrombectomy. No, the patient, if you have a large vessel occlusion, if the patient comes to you within the window period of 4.5 hours, and still there is a time for thrombolysis, go ahead with thrombolysis. But since it's a large vessel occlusion, lysis itself may not lyse the clot totally. It's a large clot burden is large. So that go next with thrombectomy, that is bridging. And suppose the patient comes to you already late, about 10 hours later or 12 hours later after the stroke onset, there is no point of thrombolysis because it is out of window period. You go for a direct thrombectomy without bridging with lysis. That's it, sir.
Thank you, sir. That's a wonderful presentation. And I just want to know, all these cases presented were successful cases. Is there any difficulties in you come across?
Yeah, very good question. We always present only the successful cases. We do have failures. Like how it happens, thing is sometimes, as I told you, they cannot reach the clot because of a very tortuous vessel. If they try more than 3-4 times, if they try to reach, the vessel might rupture. That's one thing. Another thing, it's ICAD, intracranial atherosclerotic disease, atherosclerotic wall, and the clot is very adherent to the wall. So if you try to remove the clot, you might rupture the inner layer. And likewise, if there's a dissection of the vessel, after reaching, probably you'll injure the vessel. And we have had the experience of the stent getting dislodged from the C2 and going to some other place. One example I'll tell you. We had one basilar artery occlusion. The basilar artery occlusion, we tried to put the stent in the basilar artery. That stent at the entry of the basilar artery got dislodged, went to the popliteal artery on the left side. We are reaching from the right side to the left side, popliteal artery. Popliteal artery, then we called the vascular surgeon. He said, no, we have to remove the thing by opening the vessel. Then we waited for 2 days. It seems to be worsening, seems to be getting ischemia of the limb. So we removed it by help of vascular surgeon. That happens. What other things happen? Revascularization or reperfusion injury and bleeding. If it is a clot is little larger in size, core, central core, and the penumbra is little less, unfortunately, if the collaterals are not very well made out, if you try to do the thrombectomy at these cases, you get reperfusion and bleed, hectic bleed. So whatever bleed we had, symptomatic, SIC, symptomatic intracranial hemorrhage, and we had to lose 1 or 2 patients. Yes.
So the selection is very important.
Selection is important. That's what, even if it is window, here the window period we say is 6 hours. Good for the patient, good for the doctor, because small core, large penumbra, reasonable collaterals, window period 6 hours, success rate is good. But if the window period, out of window period, 10, 12 hours, 18 hours, core is large, penumbra is small, collaterals are poorly made out, then we are in trouble. Yes.
I would like to add a comment. Our young neurologists have to be trained
Yes, yes,
as
sir. Yes, sir.
interventional neurologists.
Yes, sir. Yes, sir.
Already interventional cardiologists are available. Something like that, our young neurologist has to be trained as an interventional neurologist.
Yes, sir. Sir, now we have started training. Our young active team is there. 3 of our PGs. If they are interested, we will be training them.
Sir, one thing, sir, in fact, I was looking at the basilar artery occlusion. See, the posterior circulation distinctly behaves differently than the anterior circulation.
Definitely.
That's what I found is, in fact, our last 70, I was telling them, one practicing gastroenterologist logged in syndrome 76 hours. Symptoms started 4 days back with giddiness and all. 76 hours, sir.
Yes.
He came to us with logged in. We offered the boy that the risk is high. Beyond the period, he agreed. The basilar artery, the thrombectomy done in the basilar artery is practicing now.
Yes, sir, you are exactly 100% correct, because the collaterals are good in the basilar artery, posterior circulation. Compared to the arterial circulation, the collaterals are good, so that sustainable even after, as you said, 72 hours, young age, yeah, definitely, it helps.
96 is the last year. They have done abroad, they have done 97 hours. I think that is the highest time window they have.
Yes, sir. But we have the experience of doing up to 36 hours, sir. Not more than that.
So one last question. So can you throw some light on tyrofibin infusion after thrombolysis, sir?
Yeah, very good question. Not after thrombolysis. The thing is, of course, we have been using this tirofiban in a patient after mechanical thrombectomy. Mechanical thrombectomy, if there is reocclusion, try to rather second pass and third pass. Still, if it is reoccluding, yeah, you try this balloon. If still it is reoccluding, before going for stenting, you use tirofiban intra-arterially. Then after maintain with intravenously perfusion. Intra-arterially 1/10, that's 10 ml, is given over 5-7 minutes. Intravenously given for about 10 hours. Okay, that's you can do. But after lysis, if you do give thyrofiban, you tend to get reperfusion injury and bleed, cerebral hemorrhage. So what you can do, a small vessel occlusion where large vessel is totally okay, but presenting out of window period, infarct is there definitely. Such as these patients, up to 7 hours, you can give tirofiban infusion. Yeah, that also, the initial 10 ml, 100 ml vial tirofiban, initial 10 ml as IV bolus and the rest as infusion. We usually give over 18 hours, the remaining 80, 4 ml per hour, 90 ml. Yes.
Thank you, sir, for an illuminating overview on advanced endovascular therapies. As a gesture of our gratitude, may I request Dr. Captain K. Govindarajan, Senior Consultant Neurologist, to hand over the gifts to the chairpersons. We invite the chairpersons to the dais. Thank you all. We'll now take a break for lunch. The session will be resuming in half an hour, by 2 o'clock.
And though IVT and EVT are applicable in pediatric strokes also, but there are a lot of limitations and restrictions because of various causes like delayed diagnosis, various etiologies, and there are a lot of nuances in that. Being the first pediatric neurologist in Coimbatore, Dr. Manivasan will share his knowledge and experience in stroke patients in pediatric age group. Welcome, Manivasan, you can present your paper.
Respected teachers, colleagues, and my dear friends, I am extremely thankful to the trustees and management of Ramakrishna Hospital, Dr. Aswan sir, Dr. Vedanayagam, and Dr. Aruna Devi. So, this is a wonderful afternoon, and so I would like to say a few words about the stroke in children. I am extremely thankful to my patients also, because apart from teachers, my teachers and friends, and I learn a lot and I gained a lot from my patient, and I feel they are the one who they stimulate me to read more and more. So I am thankful to my patients as well. So pediatric stroke is not one and the same. So when compared to the adult patient, it is unique, and so we can say several factors for that. And the first one is etiology. So etiologically, so it's unlike in adult patient, it is something different. It is not the same as you see in adult patients. And pathogenesis is different, and we see a lot of metabolic and genetic causes for stroke. So even though not in true sense they are not stroke, but stroke-like episodes we are seeing more common, and stroke mimics also we are seeing more often, and in pediatric population. So if you take it, the incidence, it is 2 to 6 per 100,000 children per year, and this is there is no control study in India. This incidence, approximate incidence in hospital basis, not on population basis. So it is only there are quite a very few data we have, and this incidence, this data is restricted to hospitals, not population based. So if we take it, so neonates, so stroke in neonates, it's 80% it is ischemic, and it is 20% only hemorrhagic. Whereas in older children, it is almost equal. So hemorrhagic stroke is also it is more common than in neonates. It is a 40% when compared to the 50% of ischemic stroke. So the flow will be like this. So what are the challenges we have in children and pediatric versus adult stroke? And stroke mimics evaluation, how will you evaluate, and the treatment, and a few interesting cases. So the challenges, as Sir said, and there will be a delay. So there will be a delay, and unlike in adult patient, it is not a typically, so we cannot blame the parents, because it is not typically a hemiplegia or a speech disturbance or ataxia as you get it in adult patient. In children, it will be a simple encephalopathy, simple altered sensorium, and there will be a seizure, nothing else. So we cannot say the parents are not keen. And the presentation is not typical as you get in adults. So it is no doubt, and they may not seek medical help immediately. And performing MRI, so it's very difficult. So we cannot do it, even though if they come in a window period, performing MRI, it's very, very difficult. Sometimes they may require general anesthesia, and stroke mimics. So there are a lot of things which mimic stroke, and we have to rule out and before giving him appropriate treatment for a stroke itself. So for a neonatal stroke, you see thrombophilia, as you see in older children or adults. Thrombophilia testing is not indicated because this is very rare in newborn first. Then the normal levels will be at least 30% less than that of adults, and misleading, which will mislead us. So it is not mandatory to test for thrombophilia newborn, But however, if it is abnormal, it has to be reconfirmed later on. So newborn, they require only symptomatic treatment, and there is specific treatment like antiplatelet agents and heparin is not indicated unless in specific situations. So heparin, cardioembolic or thrombophilia or dissection. So otherwise, we do treat these children neonatal stroke and symptomatic treatment, and usually they recover very well and without any specific treatment. So hemorrhagic stroke, see for example, so it is also common in children. So it is most of these cases are due to the arterial hypertension, and mostly this hypertension due to the renovascular. So it is common in nephritis, quite common in children, and secondary hypertension which will produce a bleed. And next common hemorrhage is a tumor with the bleed. And so vascular malformation, AV malformation is quite common. It's not uncommon. And so this is upcoming. So illicit drug use, and nowadays it is upcoming. And methamphetamine, sodaphenyl, phenylpropylamine, all these things will produce so hypertensive crisis. And they release simultaneously all the three neurotransmitters, so dopamine, serotonin, norepinephrine, producing a hypertensive crisis, and they are more vulnerable for hemorrhagic stroke. And so this child is case of nephritis. So acute accelerated hypertension produces hemiplegia with while on treatment for nephritis, this child developed a hemiplegia on the left side, and this is CT. You see the large hemorrhage in the capsuloganglionic area. So what are so some differences between childhood and adult stroke. So in childhood, this is the commonest cause is vasculopathy. So unlike in adults, we see diabetes, hypertension, smoking, alcohol, and other dyslipidemia. So in children, the commonest cause of stroke is vasculopathy, and that too is post-varicella. So if a child gets a varicella, and if the child develops stroke after a couple of weeks, and it is mandatory to rule out the vasculopathy due to the varicella. So vasculopathy is a quite common cause, leading the list in pediatric stroke, and followed by hematological. Either it may be a cellular element, maybe anemia, sickle cell anemia, simple iron deficiency anemia sometimes can produce a stroke, and then coagulopathies, hereditary coagulopathies, and hereditary hypercholesterolemia, and cardiac, cyanotic heart disease, and acyanotic, and cyanotic above 2 years it is abscess, less than 2 years it is more common, thrombotic in cyanotic heart disease, and lot of metabolic and genetic causes. For example, mitochondrial cytopathies, mitochondrial disease, as well as acidemias, organic acidemias, and urea cycle disorders, and there are various genetic syndrome which can produce stroke in children. So it is diagnosis difficult and difficult to elicit signs. Most importantly, this is a lifelong disability. That is very, very important. So this increases the burden on the family, not only in the family, for also the society as well. So they have to suffer a long period. Suppose if a child develops a stroke in less than 5 years, see, imagine. So it is very, very difficult to manage these children. And the cognitive impairment, this is quite common in children, unlike in adults. So in a stroke in a younger child, usually they will have a cognitive impairment, lot of behavior problems. So we have to manage in these children. But after all this negative aspect, the most important positive aspect is they improve much more. Even a dense hemiplegia in a child will recover almost 100%. So this is because of the lot of collaterals they have and the plasticity of the brain in younger children. And if a child develops aphasia in less than 18 months, and usually the speech will recover because the continence develop only after 18 months. These are all the positive aspect of the stroke in children. How will you evaluate? Primarily a cardiac, then vasculature, vasculopathy, then coagulation problems, and especially if there is a history of thrombosis in relative, 3-generation history you have to take. If there is any positive history of thrombosis, and the thrombophilia assessment is mandatory. Vasculopathy may be due to either atherosclerotic or non-atherosclerotic. Atherosclerotic mostly due to the hereditary hypercholesterolemia and hyperhomocystinemia. This will produce both vasculopathy as well as hypercoagulopathy, homocysteine. Simple thing, it may be due to methylene, MTHFR mutation, or B12 or folate or pyridoxine deficiency. Non-atherosclerotic may be either inflammatory or non-inflammatory, inflammatory, infective. So almost most of the infection, CNS infection, meningitis can produce either bacterial, viral or fungal, can produce some amount of vasculitis, and some children may develop a stroke because of the infarct due to the vasculitis associated with the CNS infection. And it may be also due to the inflammatory, non-infective, most of the collagen disease can produce vasculitis. And non-inflammatory and most commonly a trauma in children, any trauma to the neck while playing, inadvertent, accidental fall, a trivial trauma to the neck can produce dissection of the internal carotid artery at the skull base. The classical finding will be a neck pain with Horner syndrome, ipsilateral Horner syndrome and ipsilateral plus or minus monocular blindness because of the carotid ophthalmic occlusion. This is a clue. So if a child develops a stroke on the opposite side, if there is a pain over the neck on the opposite side with hemiplegia on the other side, and with the ipsilateral Horner, and so this is a clue to this child might have had a dissection. This is very important to identify because we have to use heparin in these cases, dissection. Then various moya, this is also not uncommon. This is a progressive narrowing of the intracranial vessels and internal carotid artery, anterior circulation most commonly, then also in the posterior circulation, and producing a puff of smoke like thing in contrast thing, imaging. And there are various genetic syndromes like so ACTA, COL, A41, adenosine all these things can produce a non-inflammatory vasculopathy. So all these things we have to rule out in certain, we will have a certain clue, I will come to that later. So how to pick up these cases if there is a stroke. As I said, if there is a history of varicella, or maybe herpes or varicella, and if the child develops stroke after quite some 1 or 2 weeks, and it is mandated to do a CSF and to look for the IgM antibodies as well as for the PCR for herpes virus. This is because this is vasculopathy due to the post-varicella vasculopathy, quite common in children. And then if there is a hypermobility and maybe due to the connective tissue disorders, and this is very important. Suppose if the stroke does not conform to the vascular territory, so it does not, it involves the multiple areas or pure white matter in part, and 2 things we have to rule out. One is mitochondria and POLG1. So POLG1 is a mutation in the nuclear DNA which influences the mitochondrial DNA. So it is not the mitochondrial DNA per se, but it is a nuclear DNA mutation producing an influence of mitochondrial, which will affect the mitochondrial DNA. So this is due to the stroke here. We cannot, in true sense, they are not stroke, and it is a stroke-like episodes because there is no vascular occlusion, but because stroke occurring in these children are due to the energy failure. And suppose if there is a migraine, history of migraine, and there is a porencephaly, this is quite common. Due to the, if you happen to see a child with residual hemiplegia, if you take a CT, if there is a porencephaly, and this is, we have to rule out COL A41, 4A1 mutation, because this is more common to produce hemorrhage. And hemorrhage, because this is very important for the basement membrane of the vessels. So any derangement in the integrity of the basement membrane of the arterioles will be affected and leading on to the hemorrhage, and this will produce a porencephaly. So if you happen to see a residual hemiplegia with porencephaly in CT, always rule out COL 4A1. So this is a old bleed in caudate nucleus with the resulting in the porencephaly. Another clue will be a livido racemosa. We usually see a livido reticularis in patient, and this is due to vasospasm in cold. Whenever you are exposed to cold, this is a network-like appearance in the skin, and because of the poor blood supply in the cutaneous arteries. And livido reticularis. Livido reticularis, this is racemosa, is something different. In that, livido reticularis is bilateral symmetrical, livido racemosa is asymmetrical, and this will be permanent. And if you happen to see a stroke with the livido, and these are all the conditions. These are all the quite 4 conditions you have to rule out. One is adenosine deaminase deficiency. This is a vasculitis with the hepatosplenomegaly and cytopenias. If there is a, so livido plus hepatosplenomegaly with the cytopenias, and rule out this adenosine deaminase 2, and that because the treatment is as well as steroid and hematopoietic stem cell transplant. We have a treatment. So identification is very, very important. And then Sneeden syndrome, this is a non-vasculitis. This is arteriopathy, thrombotic arteriopathy, and usually antiphospholipids will be positive in some cases. And then ACTA2, this will produce aortic aneurysm. There is a stroke with aortic aneurysm and aortic dissection and moya-like picture in MR and congenital mydriasis. This is we have to rule out ACTA2. And Fabry, it's a multi-system involvement, so cardiac, renal, and painful neuropathies, acroparesthesia, and angiokeratoma. This is a clue to the Fabry. And this is a lysosomal storage disease, and we have a treatment, enzyme replacement therapy, agalsidase. So identification of certain syndromes are very important because we have a specific treatment. So this moya disease, you see the internal carotid artery is occluded here, and there is we are not seeing MC or ACA, and there is a lot of collaterals here, and with the corresponding infarct in the left side, frontoparietal. This is a post-varicella vasculopathy. You see that basilar artery is occluded here, and there is an infarct in the right cerebellum. So this is a quite common tuberculous meningitis with vasculitis. On the left side, you are not seeing ICA, MCA, and there is a walled infarct on the left hemisphere. And roll-up pattern foramen ovale. So it is long been debated. Is it the cause for stroke? But it is uncertain. So we cannot say it is unclear and uncertain. But however, the PFO with the right to left shunt is more prevalent in children with the cryptogenic stroke. So after ruling out all the causes, and the chance of PFO is more common in those children. So, but its relation with the stroke, it is quite unclear. So what are the metabolic disorders? So mitochondrial disease, because mitochondrial, this will produce, you know very well the mitochondria is responsible for the respiratory chain. So energy production, ATP is mainly happening in the mitochondria. So any disorders of mitochondrial mutation will reduce the ATP generation, and there will be accumulation of lactic acid as well. So, and this is lactic acid accumulation along with energy failure, and there will be a lot of this thing, glutamate. So increased glutamate, increased lactic acid, and reduced ATP. All these things produce neuronal failure, energy failure, resulting in a stroke-like episodes. And then organic aciduria, so methylmalonic acidemia, this propionic acidemia, isovaleric acidemia, all these things will indirectly affect the mitochondria and thereby producing a stroke-like. And one clue is here, in addition to the stroke, you will have an extrapyramidal syndrome. So organic acidemia will affect the basal ganglia, and there may be Parkinson or dystonia or chorea. So this is in addition to the stroke, if you get an extrapyramidal, and if you suspect a metabolic and parameters are acidosis, if there is a metabolic acidosis, and you have to rule out, so this organic acidemia. And urea cycle disorders, here you will get a hyperammonemia and without liver disease. So liver is normal, but still the ammonia is high. So, and then you have to rule out urea cycle disorders. This is a mechanism of stroke in mitochondrial diseases. And mitochondrial disorder can also produce angiopathy, which is also responsible. This is a old infarct on the, so sometimes this may be interpreted as asymmetrical lateral ventricles, but it's not so. If you interpret with the clinical means, and you can say this is a old infarct in the, sitting on the left corona and produce a right hemiplegia. You can see the fisting of the right hand, but you see the child is having a right hemiplegia also. So this is a old infarct on the left corona radiata producing the ex-vacuo dilatation of the left lateral ventricle, resulting in the right hemiplegia and fisting on the right side. This is bilateral TA contracture, equinus deformity with bilateral fisting, and this is not stroke, but it is due to the HAE sequelae. So what is the aim of treatment as naturally? So to minimize the brain injury during acute phase and preventing the long term, it's a way to prevent the impairment and disability. And heparin, okay, so we are using heparin in specific situation, and then gold standard is antiplatelet agents. 3 milligram clopidogrel also can be used, and thrombolysis, mechanical thrombectomy will come to later. So heparin, these are the indications where you use heparin, arterial dissection, embolic, if you suspect a cardioembolic, hypercoagulable state, and CVT. So there is only one study regarding thrombolysis, that is a TIP study and thrombolysis in pediatric stroke, and this has been, but this has been aborted because there is only one child has been recruited in the international study. So it has to be stopped, and there is no thrombolysis, there is no study as of now regarding thrombolysis in children. The current practice is use only thrombolysis being practiced only in those children more than 16 years of age. So as per the adult acute ischemic stroke protocols, that too in the expert pediatric stroke centers, not in everywhere. Thrombectomy, of course, it will be useful in large vessel occlusion, IC and proximal MC or basilar occlusion, and NHS more than 6 or more than 6, and when there is, this is similar to the adult, but so it is very rarely practiced in children, pediatric population. It is only theoretical. So these are the stroke mimics. So migraine with the complicated migraine can produce hemiplegia and postictal paralysis. Any infarct and seizure may be due to the, and weakness may be due to the postictal. Postictally can also occur. And cerebralitis can mimic a posterior circulation stroke, and so lot of musculoskeletal causes so can mimic a stroke, and we have to rule out. If there is a pain, and we must be very careful. So then psychogenic also. So this child present with the ataxia, you see the cysticercosis sitting on the brain, so midbrain produce ataxia and not a stroke. Heterotopias, lot of heterotopias not only produce seizure but also can produce sometimes weakness. This you see the gray matter in the sitting on the white matter, heterotopias. So what will be the recurrent risk? In neonates it is very low. However, in older children, 1 in 10 children will have another stroke within a year. Suppose with the arteriopathy, it will be more. So 1 in 3 will have a recurrent stroke. Posterior circulation, higher recurrence. So we'll see quite few cases, and this is a 10-year-old boy, and development-wise normal. He developed right hemiparesis. Then later on, after 1 year, he developed left hemiparesis. There will be a recurrent stroke. And there will be a partial recovery. He had quite a few caveolized parts, and however, there is no neurofibroma, and cognition is normal. You can see the left upper limb drifting and left facial weakness. This you see this is a CT picture, so acute infarct on the right frontal. So there is a right frontal acute infarct and left parietal walled infarct, so corresponding to the right and left hemiplegia. There will be occlusion of the supraclinoid ICA and the amount segment of both MCA. So however, MR angio neck quite normal. This is MRI, you can see the acute infarct on the right side. This is MRA, so MCA, ACA, and so tip of the ICA, intracranial ICA has been occluded. So MR angio neck normal. This is a Moya-Moya disease. And Moya-Moya can present as either TIA, ischemic stroke. However, there may be hemorrhage stroke is also possible because of the variability of the vessels, and it can produce also epilepsy. So treatment is to give aspirin, heparin, which is very, very risky, and physiotherapy. DSA confirms the finding. There are a lot of left ICA, there will be a dural collaterals, and usually they arise from the ethmoidal and recurrent meningeal branches of the ophthalmic artery, internal carotid artery, and left ECA dural collateral arises from the middle meningeal artery. And there are a lot of Moya-Moya collaterals as well, and usually we see the Moya-Moya collaterals around the circle of Willis. And collaterals among these vessels in the circle of Willis produce a Moya-Moya collaterals. And there is these are the possible collaterals in Moya-Moya disease: leptomeningeal anastomosis among the ACA, MCA, PCA. There will be anastomosis among the ACA, MCA, and PCA, and then transdural collaterals from the external carotid arteries, middle meningeal artery and superficial temporal artery with intracranial arteries, and from the ophthalmic artery and ethmoidal arteries form the frontobasal collaterals. So sometimes the angiographic finding, a puff of smoke can be seen in several conditions, need not be a Moya-Moya, and this is known as Moya-Moya syndrome, and you see it in neurofibromatosis, type 1, Down syndrome, sickle cell, and cranial irradiation, as well as ACTA1. Then the aim of treatment is to augment the intracranial flow using extra, since there is occlusion of the ICA, internal carotid artery system, and we have to get the blood from the external carotid system. This is the principle, and either it may be done directly, so direct communication between the external carotid artery and the internal carotid artery can be connected. This is a direct communication, and for example, superficial temporal artery, middle meningeal artery, these are branches of the external carotid artery, and we can connect it with the cortical branch of the MCA, with that is the internal carotid system, or occipital artery of the external carotid system with the cortical branch of the PCA, internal carotid system, basilar system. So, or it may be we can pace the vascular tissue supplied by the external carotid, that is a temporalis muscle. Temporalis muscles along with the medial meningeal artery or superficial temporal artery, along with the superficial temporal artery, we can place over and dura over the brain, so that the collaterals will arise. This is an indirect method. And this child, this boy, so our patient, he underwent right frontotemporal craniotomy and encephalodurosynangiosis. Encephaloduromyosynangiosis, that's nothing but encephalobrain. We are placing the dura mater along with the superficial temporalis muscle with the superficial temporal artery over the brain, so that the collaterals will peep into the brain, producing a circulation. And he underwent left side 1 year later. So he underwent double side edmas. This after 6 months after the surgery, almost he recovered beautifully. These are collaterals you see, this after surgery, post surgery. You see a lot of collaterals here on both sides. So he was put on aspirin. So aspirin we used to give not only symptomatic patient, but once you diagnose, without asymptomatic children should also receive aspirin. And oral anticoagulants should not, very dangerous. Sometimes it can produce bleed. There is no use of oral anticoagulants here. And another case, there is a 3-year-old child, there is a global development delay, and there is a episodic weakness. So, and producing alternating hemiplegia. Once there is one episode right hemiplegia, another episode left hemiplegia, sometimes quadriplegia, and there is a seizure as well. The child usually recovers over a period of few minutes to few hours. Sometimes it lasts for a few days also. So maximum 7 days, then remain as then gradually. This time the child is having a right hemiplegia. Uses our left hand to lift the right side. So this is due to the ATP1A3 mutation. This is a candidate gene for the producing alternate hemiplegia in children. So now the child was put on flunarizine. We have a treatment. So flunarizine will usually reduce the frequency, if not give a cure. This will reduce the frequency and it will reduce the duration as well. And other drugs, we can give a sodium valproate, benzodiazepine, or topiramate can also be used here. See, with the treatment, the frequency of attack reduces much, and once in 2 months, once in 2 to 3 months, the child develops hemiplegia, but the duration will be very less. And within 1 to 2 hours, the child recovers totally. Earlier, they used to have 3 to 4 episodes every month. This is another child, 5 months old. This absolutely developmentally normal child. And the initial presentation is a seizure at 3 months of age. And then episodes of floppiness, similar to the previous child, episodes of floppiness, quadriplegia, and they last for short period. But unlike other child, this maximum is 1 hour, and then no LOC during the weakness. So development, normal development, seizure and episodic weakness, MRI brain normal. Now the child is almost quadriplegic. Within 15 minutes the child used to recover almost normally. This is a seizure. So able to lift the right leg little bit. Fully conscious. So this is PRRT2 mutation, because this is usually primarily PRRT2 is usually concerned with the paroxysmal kinesogenic dyskinesia and infantile convulsion choreoathetosis, and hemiplegic migraine is relatively rare. So this is not the primary presentation here. It is usually a PKD, ICCA and benign familial infantile seizure. Usually this carries a good prognosis and development will be normal. The weakness will be very short duration when compared to the ATP1A3 mutation. Here the treatment will be since this is because sodium channel mutation, sodium channelopathy, and usually there will be a good response to carbamazepine or oxcarbazepine here. So sometimes this child is, since because this will act on both seizure as well as the hemiplegia weakness, so the child was put on carbamazepine, and this almost the child is now asymptomatic, no recurrence. Development wise normal, same child. So this identification of certain symptoms is very difficult. So the takeaway message is the stroke we do get in pediatric population, and so we have to rule out stroke mimics before starting with a specific treatment, and aspirin or clopidogrel can be used in ischemic stroke, and thrombolysis as of now it is only more than 16 years, and that too in specialized centers, and role of thrombectomy is negligible, and so all these children they grow into their disability as the child grows on. However, with the growth there are new deficits will emerge because of the growing brain. So thank you so much.
Many, is it true that posterior circulation strokes are very uncommon in children?
Yeah, it is relatively uncommon, sir.
Is it there? You have seen some cases?
Yeah, very rare, sir. Very rare.
So that was a wonderful talk, sir. For the sake of audience, how long do we give aspirin for these children with strokes?
So usually the aspirin is for 2 years. The recommendation is 2 years. It depends upon the etiology once again, but without any risk factor, without any comorbidities, so usually used to give for 2 years.
Yes. And it looks very rare, but I would say we have seen all these cases. It is there. Only we now with evidence availability of these genetic tests, we are able to make this diagnosis, and treatment options are also available. For many of them, treatment is simple also.
Sir, is there any indication for doing this genetic testing? For do you do screening like most of the children, or you decide by clinically?
Say suppose, for example, child having a recurrent stroke-like episodes, and MRI is normal, and if there is associated finding, so you don't get cardiac and you don't have thrombophilia negative, and then it is mandatory to rule out either metabolic or genetic. Everything is normal to go for a genetic normally. And the clue will be for metabolic will be acidosis and hyperomonemia.
Poor encephalitis is many times we see, no, sir, but there is nothing antenatal or in the perinatal period. We have to rule out col4A1 mutation. It is known to cause presenting with poor encephalitis.
Excellent, extraordinary presentation, sir. Thank you, sir.
Thank
Thank you, sir, for highlighting the management of pediatric stroke. As a gesture of our appreciation, may I request Dr. Ravi Kumar, Senior Consultant Physician, to hand over the gift to the speaker and chairpersons. We request Dr. Neelakantan to kindly give away the gift to the speaker and the chairpersons.
Thank you all. Our next session focuses on antiplatelet therapy in secondary stroke prevention, an essential pillar in preventing future stroke events. We have with us Dr. B. Prakash, Senior Consultant Neurologist, KMCH, to walk us through this session. Chairpersons for this session are Dr. C. Kanagaraju, Consultant Neurologist, Royal Care Hospital; Dr. R. Balakrishnan, Professor and HOD, Department of Neurology, PSG Hospitals; Dr. M.G. Binnu, Senior Consultant Physician, Sri Ramakrishna Hospital.
Welcome, and I think we all have doubts when to use single antiplatelet, when to use double antiplatelet, whether to give a loading dose for acute stroke, and how long to continue double antiplatelets, when to use ticagrelor. So I think we all have, even though there are a lot of good guidelines, we all have practical difficulties in managing patients, because we see sometimes patients come with even stroke after double antiplatelets. So I think Prakash, I think is well known, and he's going to clear all our doubts regarding. He's going to clear all our doubts. So when to use single antiplatelet, when to use double antiplatelet, when to use aspirin, when to use clopidogrel, when to use ticagrelor, and what are the chance of patients getting a stroke after single antiplatelet, double antiplatelet, and what are the incidence of aspirin resistance and clopidogrel resistance. So I think he's going to clear all our doubts. So I just welcome Dr. Prakash to give a lecture on antiplatelet therapy for secondary stroke prevention.
Good afternoon to all. I thank Dr. Ashokan sir and his team for inviting me to give this lecture, and thanks for asking all the questions before the talk. And we are going to see antiplatelet therapy in secondary stroke prevention, and this is a very specific talk. And stroke is a leading cause of long-term disability and death globally. And global stroke incidence is 1.2 crores and prevalence is 8.3 crores. The mortality is 70 lakhs and economic burden is 7,900 crores in 2017. The secondary stroke prevention is a critical component of stroke care to minimize the risk of recurrence. Antiplatelet agents are the cornerstone of medical therapy. This presentation will explore the current evidence, clinical guidelines, and future directions of antiplatelet drugs. Despite effective prevention, stroke incidence increases mainly because of increase in life expectancy. 75 to 85% of ischemic stroke patients survive in the first stroke, but the recurrence rate is very high, that is 8 to 15% in the first year. In a meta-analysis of 287 trials with 1,35,000 patients, antiplatelet drug reduces the risk of serious stroke recurrences by 25%. The studies are ongoing in regard to choice of antiplatelets, combination, when to start and when to stop, etc. The etiology, there are tremendous efforts have been made in the management of cerebrovascular disorders. Ischemic stroke is more challenging to treat than coronary artery disease due to the variety of mechanisms that can lead to cerebral ischemia. The stroke subtypes include cardioembolic stroke, cryptogenic stroke, large artery atherosclerosis, small vessel disease, and other etiology. The pattern of stroke recurrence varies by its subtype. If you take large artery atherosclerosis, the recurrence in early phases are high. If you take cardioembolic stroke, the long-term risk is steadily high over a period of years. The immediate period after the stroke is a target for sensitive therapies like thrombolysis and endovascular thrombectomy, as the previous talks given. The therapeutic goals beyond this stage is to reduce the stroke recurrence and to prevent the medical complications. Antithrombotic drugs are again the mainstay of preventing recurrences. Coming to some of the type of strokes, lacunar stroke is a non-cortical infarct caused by thrombosis or lipohyalinotic occlusion of the deep penetrating vessels, and cardioembolic stroke is a stroke attributable from the embolus that arises from the heart, and large artery atherosclerosis stroke occurs in the large intracranial or extracranial artery with more than 50% stenosis. Clinically, they manifest like a cortical brainstem cerebellar involvement, and the lesions are usually more than 1.5 centimeter. Diagnostic studies should exclude cardiac source of embolism. Regarding ICAD, carotid disease causing stroke, TIA, and amaurosis, which is often recurrent. ICAD is most common vascular lesion among the strokes all over the world. Asian and blacks is the highest stroke recurrence rate. 30-day risk of stroke recurrence is 5%, and 1-year risk of stroke recurrence is 15%. The secondary prevention include, there are a lot of studies. Initially, they focused on aspirin only, and Japanese studies are there. This CAPE study, clopidogrel was not proven to be better than aspirin. They initially tried with clopidogrel, and Socrates study says they tried ticagrelor, which has shown no overt benefit than aspirin. Japanese study, they tried with prasugrel, but there is no benefit. So all of these studies say aspirin is again better. Regarding cryptogenic stroke, stroke is confirmed by imaging. Already stroke is confirmed, but the source remains unknown. Cryptogenic stroke constitutes about 30 to 40% of all the ischemic strokes. The sources could not be made out easily despite of thorough assessment like arterial imaging, echo, and cardiac rhythm monitoring, and key laboratory studies. The risk of recurrence is also high, 1.6% in 7 days, and 4.2% in 1 month, and 5.6% in 3 months. Several possible mechanisms may underlie cryptogenic stroke like paroxysmal atrial fibrillation, atrial cardiopathies, paradoxical embolism like in PFO, and substenotic atherosclerosis. So these are the types of stroke like small vessel disease and cardioembolic stroke and intracranial atherosclerotic disease and extracranial and other undetermined causes, cryptogenic stroke, etc. Stroke and antiplatelet drugs. Platelets are activated by collagen, ADP, and arachidonic acid metabolite thromboxane A2. The activated platelets induce platelet aggregation and blood clot formation. Antiplatelet agent inhibit platelet aggregation in several ways. Aspirin, clopidogrel, ticagrelor, tirofiban are commonly used antiplatelet drugs. They are classified according to their mechanism of action like COX inhibition, P2Y12 receptor blocker, and GP2B3A inhibitor and phosphodiesterase inhibitors. So the classical drugs include aspirin, ticlopidine, ticagrelor, tirofiban, and dipyridamole. These are the site of platelet activation and the drugs acting at the site. Aspirin is the oldest and most commonly used drug in the world. Aspirin is a standard medical therapy. It prevents stroke in TIA, reduces stroke recurrences, and prevents restenosis after CEA. Aspirin is effective if started within 48 hours of stroke. It is inexpensible and safe. Aspirin reduces the combined relative risk of stroke, MI, vascular death by 25%. The recommended range of daily dose is between 50 to 325 milligram. The effectiveness, it's effective as low as 30 milligram per day. The higher doses may cause GI side effect. Aspirin acts by inactivating the COX isoforms. This inhibition of platelet function is irreversible. The anti-aggregant effect is seen within 1 hour after administration. Aspirin is also anti-inflammatory and antioxidant. Aspirin may increase fibrinolytic activity up to 4 hours after administration. The main effect of aspirin is gastric discomfort. GI hemorrhage occurs in 1 to 5% of patients. There are a lot of evidences which say aspirin is good, we all know, and these trials say again aspirin is very good. It's an international, this is a first trial, IST trial, studied aspirin 300 milligram per day, heparin versus both versus neither. And aspirin was started within 48 hours of ischemic stroke. And aspirin group had a significant fewer ischemic strokes, but with equal rates of hemorrhage. And other studies include CAST, that is Chinese acute stroke trial, and other systematic reviews. Coming to dipyridamole, dipyridamole is a phosphodiesterase inhibitor. It increases the level of cyclic AMP. There's a European stroke prevention study, EPS2. Patients with stroke or TIA within previous 3 months, they are treated with aspirin alone or dipyridamole alone or both or placebo. Both low dose aspirin and high dose dipyridamole were superior to placebo. And the combination was significantly superior to each drug alone. The benefit was limited to stroke prevention. The side effects of dipyridamole includes headache and GI distress in aspirin. In PROFESS study, this shows clopidogrel was non-inferior to aspirin dipyridamole, and headache was higher in dipyridamole group, as said earlier. Coming to clopidogrel, it's a thienopyridine derivative. It blocks ADP receptor, that is P2Y12. It interferes with platelet cross-linking and aggregation. The CAPEA study is randomized patients with stroke, MI, and PVD. The clopidogrel group had a significantly lower annual rate of vascular events, and relative risk reduction in patients with prior stroke is 7.3%. Hemorrhagic risk were similar in both the two groups. Clopidogrel is considered as a good option for secondary stroke prevention. So this study supports clopidogrel. And coming to silastazole, silastazole inhibits phosphodiesterase and platelet aggregation. There are a few studies. These are all older studies which says silastazole is better than aspirin. This study 1 is CSPS and CSPS2 trial, and that says silastazole is better than placebo, better than aspirin, and silastazole plus aspirin, silastazole plus clopidogrel versus aspirin versus clopidogrel, and they say dual antiplatelet therapy is better, like that. And all these studies are older, and we know silastazole, we are not using silastazole in our day-to-day practice, and I couldn't find any recent studies which says silastazole is not much useful. Coming to dual antiplatelet therapy, dual antiplatelet therapy was well established in acute coronary syndrome long before stroke trials. It was needed in stroke. Double antiplatelets are needed in stroke as the recurrence rate is very high. That is 2% in 12 hours and 3% in 2 days and 5% in 7 days and 10% in 14 days. So we need to give additional antiplatelets. So in mild stroke or high risk TIA. That means if the stroke NIHS score is less than 3 and the TIA score, if it is more than 4, ABCD score more than 4, we have to go for dual antiplatelet. So initially we have to give a short-term dual antiplatelet, then followed by long-term single antiplatelet, which is preferred than single antiplatelet alone. And dual antiplatelet beyond 90 days after stroke leads to increased risk of bleeding, no benefits of risk reduction. In untreated stroke, over few weeks, use of any single antiplatelet is indicated. That means if a patient comes to you after 3 weeks or 4 weeks of stroke, you have to use single antiplatelets to reduce further recurrences. Regarding the studies of dual antiplatelets, there are four important studies. The initial study, FASTER study, which was stopped because of difficulty in recruitment, and these four studies, initial two studies compared the aspirin with clopidogrel, and third study compared ticagrelor with aspirin, and fourth study stenting in stenting versus best medical management. These are the timelines of the study. To begin with, the trials were 1997 CAST and 2004 MATCH, and then PROFESS study and SPS 3 and CHANCE, Socrates and POINT studies, THALS, and ongoing CHANCE 2. These are all the timelines of studies regarding antiplatelet therapy in stroke prevention. And these are all the studies which, this graph is a very good representation of the studies. You can see the issues in the initial this thing, and small vessel disease studies were represented in the lower one, and large artery disease were represented here. And you can see the sample size is, if the sample size is small, there is a small circle, and the sample size is large, the large circle is put, and which drug is used, the color is used. And this is from 1990 to 2020, and how studies are being done. And this graph is a very good graphical representation of overall looking of all the studies which have been done in stroke. Coming to the initial study, I told 4 studies. That is, first is CHANCE, that is clopidogrel in high-risk patients with acute non-disabling cerebrovascular event. This is a randomized double-blind placebo-controlled trial conducted in 114 centers in China from October 2009 to July 2012. It is randomized within 24 hours from the event. It compared the efficacy of dual antiplatelet, that is aspirin and clopidogrel for 21 days, followed by clopidogrel alone for 69 days versus placebo and aspirin. In patients with minor ischemic stroke, that is NIHS less than 3, as I told already, high risk TAA, that is ABCD score more than 4. The result showed DAPT reduced the occurrence of stroke, and event rate is 8.2% in DAPT and 11.7% in aspirin. No increase in risk of severe bleeding was noted. Coming to second study, that is a POINT study, platelet-oriented inhibition in new TAA and minor ischemic stroke. This study was stopped in August 2017 due to major bleeding. But up to that, what happened? The major ischemic events occurred less frequently in dual antiplatelets, and occurrence of ischemic stroke was reduced, and the major bleeding was significantly increased. So that's why the study was stopped. Coming to THALS, that is a acute stroke in TAA treated with ticagrelor and aspirin, and that says stroke was significantly reduced. ICH and fetal bleeding is more frequent with DAPT. SAMPRI study compares stenting versus aggressive medical management. It says that higher 30-day risk of stroke and death in stenting, and it supports dual antiplatelets. See, the study says when you compare dual antiplatelets versus stenting, it supports dual antiplatelets. But nowadays, by selecting a particular, selecting each and every patient, we can say that stenting is good in several type of patients, patients. It helped a lot, not the dual antiplatelet, but many of the cases we need to take up dual antiplatelets, and this study supports dual antiplatelets. What is the duration of dual antiplatelet? As I said already, long-term use of dual antiplatelet, that is aspirin and clopidogrel for recurrent stroke prevention, has no benefit over a single antiplatelet. Significantly increased risk of bleeding is there. The problem is, initial period, there will be a very good benefit. The exact duration of dual antiplatelet at which the risk of hemorrhage begins. That means you give at the acute stroke, you give dual antiplatelet. Then for a particular period of time, dual antiplatelets are very helpful. And beyond a particular time, there is a major risk of bleeding is there. So at what time the bleeding is going to happen, at what time you have to stop dual antiplatelet and switch over to single antiplatelet. That is not known. So a lot of studies have been done. That says, few studies says 21 days, few studies says 30 and 90 days. So usually, as a well-known fact, it's older patient and severe stroke are the higher risk of ICH. The benefit of stroke reduction in dual antiplatelet is maybe maximized as early as first 21 days. But as I said already, the conversion time is 90 days. That is, you give dual antiplatelet not more than 90 days. After 90 days, definitely convert it into single antiplatelet. So that is a usual thing, except for few rare cases like if the patient has got drug-eluting cardiac stent, etc. So this slide depicts the same. I don't know if you are able to read it or not. Suppose if you get a patient, stroke patient, and it's a ischemic stroke. If the patient has got ischemic stroke, whether it is a early ischemic stroke or late ischemic stroke, if it is a late ischemic stroke, go for a single antiplatelet. If it is a early ischemic stroke, you check for NIHs. If the NIHs less than 3, yes means you go for dual antiplatelet and convert the dual antiplatelet into single antiplatelet after 90 days. If the NIH is more than 3, you go for single antiplatelet only. The patient has got TIA, the patient has got a high risk, that is ABCD score more than 4, then you go for dual antiplatelet and convert again into single antiplatelet. If the risk is low, you can go for single antiplatelet. And this chart is very useful. And coming to triple antiplatelet therapy, we are discussing whether dual antiplatelet therapy is useful or risk of major bleeding. Triple antiplatelet, definitely it increases the bleeding risk. And there's one trial, TARDIS trial, and so there's no way of thinking of going into triple antiplatelet therapy. Switching antiplatelets. This is another big question. Suppose if a patient is on, if patient who had stroke earlier, who is on antiplatelet like aspirin, and he comes back again with a stroke, second time stroke. This time there is a thinking whether aspirin is not useful, you switch over to clopidogrel. Whether that decision is correct or not, we do not know. The studies also did not conclude you have to switch to some other antiplatelets. That is not sure, except you know the patient has got a aspirin resistance. And regarding extracranial carotid disease, DIPT is not indicated due to increased chances of bleeding intraoperatively. And aspirin clopidogrel, aspirin dipyridamole is recommended indefinitely after carotid endarterectomy or carotid artery stenting. Ticagrelor needs further investigation. And regarding extracranial vertebral disease, 10 to 20% of post-circulation strokes have extracranial disease, and the same medical management is followed. 2 trials failed to show superiority of stenting. A recent trial shows stenting was safe and better. To date, no data supports endovascular intervention for vertebral artery disease. This is again individual case basis. If that means this study does not favor vertebral artery stenting. But if you select some cases where vertebral artery needed to be stented and carefully you select the patient, we can go for vertebral artery stenting, and we personally did a few cases of vertebral artery stenting where it is needed. Coming to aortic arch atherosclerosis, again we do not know what, the larger number of studies are not available, treatment data is not available, but few data are there, and they say there is no evidence of warfarin is useful, but antiplatelets are indicated in aortic arch atherosclerosis. Coming to small vessel disease, this is a totally different topic. This a cerebral small vessel disease is responsible for 25% of ischemic stroke patients, and the annual rate of recurrence is about 2 to 7%. Here, the secondary prevention of small subcortical stroke, there is one study, SPS-3, and there is one trial, match trial. There is no benefit of dual antiplatelet versus clopidogrel monotherapy. But due to the pleiotropic properties such as arteriolar vasodilatation and protection of vascular endothelium, here silastazole is effective for preventing cerebral injury in patients with small vessel disease. So there is a slight difference. In small vessel disease, we can try silastazole. Cryptogenic stroke, embolic stroke of unknown origin. The cryptogenic stroke is usually a non-lacunar. There is no evidence of LAA. Usually young patients, the rate of recurrence is 5% annually, and there are four randomized control trials were there, and anticoagulation has not been superior in uses. There are few studies which says antiplatelet monotherapy remains the treatment of choice. Cryptogenic stroke and PFO. There's a paradoxical embolism through PFO may be implicated in cryptogenic stroke, and secondary prevention strategies in this patient include PFO closure, antiplatelet drug, and anticoagulant agent. Which one to do? So, PFO closure and long-term antiplatelet is superior to antiplatelet alone, and PFO closure and anticoagulation may have similar efficacy, but data is not very good. So when PFO closure is contraindicated, the benefit of anticoagulation over the antiplatelet is unclear. That means anticoagulant is not recommended, whereas antiplatelets are recommended, and whenever needed, you have to go for closure whenever required. Coming to cervical arterial dissection, that is cervical arterial dissection is a common cause in young, and usually we give heparin in these patients, and stroke recurrence is low. So, but initial few weeks we have to, it's a high risk period, we have to give antithrombotic agents, and there is only one trial, that is a CADIS trial, which says patient received either antiplatelet or anticoagulant for 3 months after the diagnosis of CAD. The infrequency of endpoints, they cannot come to a conclusion, but in practically we used to give heparin for initial period, followed by oral anticoagulants, then followed by antiplatelets, but the duration is not very clear. Carotid web is a thin circumferential shelf-like filling defect which arises from the posterior wall of ICA bulb. Carotid web is a variant of fibromuscular dysplasia. It is classified as focal or multifocal, and platelet deposition can occur in the carotid web, and is a known cause of ischemic stroke in young. It is detected in 9.5% of ESUS patients less than 65 years of age. And as I said, fibromuscular dysplasia is a non-atherosclerotic segmental disease of small or medium-sized vessel. It can result in arterial stenosis, occlusion, intraluminal thrombus, aneurysm, or dissection. Multiple fibrous webs can serve as a nidus for platelet deposition or obstruct the flow. It can involve the extracranial carotid vertebral and renal arteries. Coming to inherited thrombophilias as well as APLA, here these two are almost similar, like we have to, the pathology is different, but the treatment point, regarding the treatment point, anticoagulation is, should be considered, and long-term anticoagulation with higher dose of, higher anticoagulant dose is considered in inherited thrombophilias because the recurrent rate is high. So also in antiphospholipid syndrome. It's an antibody-induced thrombophilia, and in systematic review, there's a APLA patients with previous stroke had high thrombus recurrence. This occurs despite antithrombotic treatment. Less than 4% of all events occurs with even with INR of more than 3. So aggressive therapeutic targets are indicated. Stroke and malignancy, ischemic stroke is common among cancer patients. The reason for stroke in cancer patients include hypercoagulability, paradoxical emboli, non-bacterial endocarditis, tumor embolization, local tumor compression, and treatment-related complications like radiation-related large vessel arteriopathy. Anticoagulation with low molecular weight heparin and direct oral anticoagulants are recommended. And after ICH, what will happen? What do you do after ICH, antithrombotic therapy? When do you start? Antithrombotic associated ICH are larger volume, and hematoma expansion may occur. The outcome is worst. So all antithrombotics should be discontinued at this time, and a systematic review when to restart. There are 5,306 patients. The time for restarting anticoagulation is 10 to 39 days. They come to a conclusion, no significant risk of recurrence if they start after about 3 months. So 12 to 43 months is a thing, but usually a median time is 2.5 to 3 months. We can restart anticoagulant, and there is no risk of bleeding. So there is a stroke recommendation, American Heart Association 2021. There is a recommendation for secondary stroke prevention. Among the take-home messages of this American Heart Association recommendation, there are 4 important points regarding the antithrombotic therapy. Antithrombotic therapy is recommended for all the patients without contraindication. Dual antiplatelet therapy is not recommended in long term. Short-term DAPT is recommended in early arriving minor stroke. That means the patient has to come earlier with a minor stroke and high-risk TIA with severe symptomatic intracranial stenosis. Combination of antiplatelet and anticoagulation is typically not indicated except for very rare cases. So antiplatelet therapy is the cornerstone of secondary stroke prevention. Early intervention with short course dual antiplatelet is recommended for minor stroke with high risk TIA, For long-term treatment, monotherapy with aspirin or clopidogrel is the standard regimen. So still we have a lot of questions. There is knowledge gaps and future research are indicated. What is the optimal combination? What is the best combination? And what is the duration of dual antiplatelet? What is the effectiveness and harm of dual antiplatelet among specific subgroup of patients? Benefit of switching antiplatelet agent who was already on another antiplatelet at the time of stroke. Effectiveness of direct oral anticoagulant with antiplatelet therapy for secondary stroke prevention. Can you combine both? And optimal antiplatelet strategies based on specific genetic profile of the patient, and the clinical benefit of platelets among the testing and antiplatelet resistance. Whether do you do it in all patients? So these are all the knowledge gaps, and thank you for the patient listening.
Thank you, sir, for that wonderful presentation. Can you just put that 54 slide?
Which
slide
one?
number 54. So, sir has taken anticipatory value with lot of conditions. So, questions can only be very few. What is your personal preference, sir? Is it aspirin or clopidogrel?
See, what I feel is aspirin is a better one, but somehow clopidogrel has been boosted in many conditions. If there is definite aspirin failure, and I have not done any aspirin resistance evaluation, but if it is so, the patient fails, we can go ahead with clopidogrel.
So, when we are using single antiplatelet as say clopidogrel, is aggregometry must? Platelet aggregometry, so that clopidogrel resistance can be there in.
If it is there, we have to. So in future, suppose if we get studies, easily available studies like resistance of clopidogrel or this one aspirin, we have to switch over to other drug.
When somebody on single antiplatelet therapy for a cardiac reason develop a stroke, what is our strategy?
It's very difficult. That's a question I asked.
Sir, actually in diabetes we have a lot of aspirin and clopidogrel resistance. Even non-diabetics, we are inheritedly, I think, resistant to aspirin also. But in US and all, I think they check for aspirin resistance and clopidogrel resistance. In PSG, we have started checking for aspirin and clopidogrel resistance in our pathology lab. If anybody is willing to send patients, they can send patients. So now they started recently. So because we see a lot of patients on double antiplatelets coming with stroke, even though the mechanism of stroke is not embolic. So even though it's atherothrombotic, a lot of people with double antiplatelet come with stroke, and when they have a normal vessels and embolic source is ruled out, and they come with this thing. So what do you do in this situation?
See, many I've seen many prescriptions which include aspirin along with rivaroxaban 2.5 milligram BD, or this one apixaban 2.5 milligram BD. I don't know whether that is recommended or not. In studies it is not there. Some people use it. I don't have any experience.
Stenting, they have used low dose rivaroxaban 2.5 milligram BD plus dual antiplatelets. Name of the study I don't remember, some COMPASS trial, something like that. So based on that, they have said that the recurrence of vascular events is less, but there is no study in the neurology. It is from the cardiology study. Some of the cardiologists are using that.
Very nice presentation, Dr. Prakash. Thank you. Two just comments. This about carotid artery dissection or vertebral artery dissection for that matter. If the dissection is intracranial, we are not supposed to use anticoagulants. They tend to bleed. So only antiplatelets, preferred. I don't say 100%, but preferred is antiplatelet. If it is extracranial dissection, then probably you can use anticoagulants. It depends, that's one thing. And the APLA syndrome, you told us APLA syndrome, yeah, almost lifelong anticoagulation. The question is whether this Novak useful for APLA But till now, lots of studies, but no one supports Novak. Still warfarin is a better anticoagulant for long-term usage. That's what. Then regarding this anticoagulation after large ICH, we do get a situation where there is ICH, patient is bed-bound, confined to bed, and matter of 10-12 days, they get a DVT. So if it is past 10 days, where no other go, we have to use, of course, all these pumps we are using, DVT pumps, but in spite of that, probably we have to use low molecular weight heparin. We can start using low molecular weight heparin in 10 days, even though there is a bleed inside the brain. These are the few comments. Okay. And your double antiplatelet, that's what everyone says 21 days or 45 days. Normally use up to 3 months. But I have seen prescriptions taking for years, 10 years plus. Still they are safe, nothing happened. But normally we use for 3 months, then after that switch over to single. And of course we prefer aspirin. The only problem with aspirin, some of them they come back with severe gastritis, vomiting, nausea. Of course you have to give along with some pantoprazole, many things. So double antiplatelet 3 months, after that aspirin is a better choice. That's what I believe. Then lastly, this 2.5 milligram business, that is actually mainly used by vascular surgeons to start with. More than cardiologists, vascular surgeons. They feel that peripheral clotting or peripheral occlusion is prevented by this 2.5 BD. You cannot take away, rather take them out of it. They strongly believe that. So that's how it started, this 2.5. Then cardiologists switched over it. Then we are also following sometimes, where there is ischemic stroke, patient is down, etc., etc. Yeah, few comments. Thank you.
Thank you.
What about patients who are already on silastazole for some other reasons, and whether you use dual antiplatelets or single antiplatelets in that
Patient
class?
already
on silastazole for some other reason, probably limb ischemia or so. So in those things, in those patients, when they come to us, whether to use single antiplatelets or dual antiplatelets along with silastazole.
Silastazole. There's no studies. We have to act as per the according to the patient, but as per the individual patient.
The problem is there are other factors also. So most often the LDL target is not adhered to. So if you are seeing only the aspirin, if you see their LDL will be 100, 120, 130, 140. If you are just focusing on aspirin, answering Dr. Binu's question, if the patient has got a CAD, patient has got another stroke, if his BP is not under control, if his sugar is not under control, if his cholesterol is not under control, he is bound to have one more event. So that is also to be addressed. So in such a situation, we have to see if that is not addressed, and that is more important. LDL target is very, very important. As Dr. Ashokan said, people are getting dual antiplatelets for more than 10 years, but if you see their LDL, they are not checked, it is 130, 140, 150, 170, sometimes more than 200 also. I think that is more important than giving sole emphasis on antiplatelets. All are important. It's not that it's only one thing, so it's a bundled approach. We need to take care of everything. If everything is taken care of, generally this won't happen. And regarding this clopidogrel resistance, it is said that it's around 30% is the clopidogrel resistance, but there is a controversy in vivo versus in vitro. See, many people do not agree. After the Chinese study, only many people started doing. Most of the cardiologists stopped using clopidogrel because of this. So after stent, they use only ticagrelor. They hardly use clopidogrel. Whereas you go, I was in Middle East for 6.5 years. Their ticagrelor usage is very less. They use only clopidogrel. So we don't know these things and all. We don't know. So there's no such. And they feel that in vivo and in vitro do not match. So you might use either.
Thank you all. Our next session underlines the foundation of hypertension and other risk factor management in stroke. This is addressed by Dr. K.K. Prajit, Senior Consultant Neurologist, Konkanad Hospitals. The session will be chaired by Dr. G.N. Lakshmi Narayanan, Senior Consultant Neurosurgeon, Dr. M. Socrates, Senior Consultant Neurologist, and Dr. V. Kannan, Senior Consultant Neurologist.
Good afternoon, everybody. I thank Dr. Ashokan and his team for inviting me and the audience for patiently waiting post-lunch session on a Sunday. So I hope I will be able to share a few points. Okay, my topic is hypertension and other risk factors in management of stroke. So these are the risk factors: hypertension, diabetes, smoking, dyslipidemia, heart disease, physical inactivity, heavy alcohol consumption, and poor diet. Now we'll go one by one. Hypertension is the single most important risk factor for stroke. So if we address hypertension, most of the problem is taken care of. If you see recently in the recommendation, things have reversed. Initially, a few years back, we were more aggressive towards diabetes and less aggressive towards blood pressure. Now it is more aggressive towards blood pressure and less aggressive towards diabetes. That is, and even from the Framingham study point on, hypertension has always been a big problem. I think that has to be addressed, starting from recording BP to medication. So it's a big problem, it needs to be addressed properly. So patients with previously known patient of hypertension has to be treated, of course. Any newly diagnosed hypertension has to be treated, and any type of stroke or TIA with a BP above goal has to be treated. Now, this is the definition of hypertension. So normal is now reduced to 120, 80 and below. Elevated is in between 120, 130 to less than 80. And 130 to 139 and 80 to 89 is taken as stage 1, and stage 2 is taken as 140 by 90. So for practical purposes, we have to say that our BP target has to be 130 by 80. Now, management of hypertension in acute stroke. So, we've all heard about thrombolysis. Post-thrombolysis, in the first 24 hours, intensive monitoring is required, and BP should be maintained below 180, 105. Labetalol usually is the recommended agent of choice. Other agents can be used, including calcium channel blockers. After thrombectomy also, the same target has to be adhered to. During thrombectomy, significant hypertension has to be avoided. And BP variability in the first 24 hours after thrombectomy is a bad prognostic sign. Now, before going further into this, this is one area which is very neglected. In the ER, patient comes with acute stroke, everybody is busy, everybody is running around, we need to get reduced door to needle time. The moment we see a bleed, all momentum is lost. Everything is lost and everybody slackens. So that is not the approach. There were some studies to intensify BP treatment. There were some studies, Interact 2, that is intensive treatment of intensive reduction in acute cerebral thrombosis, or treatment in this attached to trials also, where the final benefit was not achieved, but post hoc analysis showed benefit of blood pressure lowering within 24 hours. So they found that in Interact 3 bundle, it is a bundle care approach which helped rather than BP control alone. That means along with BP, the maintenance of sugar below 180 to 200, maintenance of normal temperature, and taking care of coagulopathy also helps significantly. Now, they proposed a door to antihypertensive time in such patients are less than 30 minutes. Proposed door to target BP less than 60 minutes. And when these two questions were answered, how much should the BP be reduced in intracerebral bleed? So the target is systolic BP less than 140 and the drop in BP of more than 60 millimeters to be avoided. This is one point which we should remember. And systolic BP of less than 100 also to be avoided. So aggressive lowering of BP in patients is questionable. That means if a patient with intracerebral bleed comes after 24 hours, there the question of aggressive BP lowering is not valid. So this happens in acute intracerebral bleed. So which agent do we choose? Either labetalol, nicardipine, hydralazine, and even enalapril is available. Avoid glyceryl trinitrate because it inhibits the protective vasoconstriction to prevent hematoma expansion. It's a combination of BP control, control of blood sugar, very useful in long-term outcome with intracerebral bleed. Now, coming back to ischemic stroke, risk factor management in ischemic stroke, hypertension. When to start antihypertensive therapy in acute stroke? In TIA, to be started without delay. In ischemic stroke not thrombolized, antihypertensive therapy to be started after 24 to 48 hours. Exceptions are extremely high blood pressure, the patient has concomitant eclampsia, if the patient has acute coronary syndrome, if there is cardiac failure or aortic dissection. In patients with fluctuating neurological symptoms, antihypertensive therapy to be delayed. Now, blood pressure in acute ischemic stroke, the reason is perfusion pressure distal to the obstruction is low, so distal vessels are dilated, and because of impaired cerebral autoregulation, blood flow in these dilated vessels is dependent on systolic pressure. I will show you the figure shortly. Blood pressure in acute stroke is usually elevated due to sympathetic response and is necessary to maintain the perfusion in borderline ischemic area. This is transient and falls within 10 days. So what are the goals of antihypertensive therapy? So in non-atherosclerotic vascular disease or in stroke, in diabetes, in chronic kidney disease, even in age greater than 65, and the high quality BP measurement targets is less than 125 by 80 and casual BP measurement is 130 by 80. So for practical purposes, around 130, 80 and below should be adhered to strictly. When there are none of the above, then you can say maybe 140 by 90, but 130, 80 is the target. So what is the choice of therapy? So choice of therapy is ACE inhibitor plus diuretic. This is a classic choice. Perindopril plus indapamide. Add on calcium channel blocker. Choice depends on comorbid conditions. And reduction of BP in patients with risk factors provides greater benefits than those without risk factors. That means if the patient patient comes with stroke and he is not a their reduction is not very much beneficial as compared to a patient who is already diabetic, hypertension, smoker, etc. So intensive BP reduction needed for patients with risk factors. Now selection of antihypertensives, choice of drug is similar in patients who have had a stroke or TIA. Monotherapy is recommended when blood pressure is less than 20 to 10 millimeter above goal. Although studies favor ACE inhibitors and ARB and diuretics, calcium channel blockers can also be used. A combination of calcium channel blocker and ACE inhibitor works very well in reducing BP significantly. There is some evidence that beta blockers may not reduce stroke risk compared to ACE inhibitors. So unless there is a compelling indication, try not to use beta blockers in stroke. Now this has to be started 24 to 48 hours after stroke onset. If treatment is indicated in the first 24 hours, 15% lowering on day 1 is suggested. BP lowering should be slower in patients with large intra or extracranial stenosis. Systemic hypotension and hypovolemia to be avoided. Again, coming to selection of antihypertensives, combination therapy, as I told you, is recommended when BP is more than 20 by 10 millimeters above goal. ACE inhibitor plus calcium channel blocker is preferred. The other advantage of combining an ACE inhibitor with calcium channel blocker is If you combine an ACE inhibitor with calcium channel blocker, the chance of pedal edema due to calcium channel blocker reduces significantly. So when the patient has a pedal edema following calcium channel blocker, generally diuretics don't help. ACE inhibitor in addition will reduce the edema. Cardiovascular events are also reduced. The PROGRESS study, that is perindoprolol protection against recurrent stroke, and PROFESS study supported these views. So in patients without atherosclerotic disease, atrial fibrillation, target BP is 135/90. However, if cardioembolic patients had associated heart failure, there the target BP is less. So in patients with intracerebral hemorrhage, intensive blood pressure lowering is recommended, as I told earlier. Now how fast? I am repeating something just for re-emphasis. Gradual BP reduction approximately 10%, although there is no consensus. In patients with known cerebrovascular disease or long-standing uncontrolled hypertension, unless there is a hypertensive emergency, you have to be slow. The reason is flow is equal to pressure by resistance. So in these patients, resistance will be high. So once the resistance is high, we reduce the pressure soon, the flow will become slow very soon. And this may be impaired in chronic hypertension. So arterial thickening is an adaptive response to prevent high blood pressure. This limits the ability to maintain perfusion when the BP is lowered. So you see this chart, here it is very clear, the red is the normotensive, blue is the hypertensive patients. So in hypertensive patient, to increase the cerebral perfusion, the mean arterial pressure has to be significantly higher. Similarly, if the mean arterial pressure reduces just below normal, the perfusion pressure reduces very soon. So this is an important figure which you have to keep in mind, and this is very, very important in the ER. The first visit is done by the ER medical team. When we are not thrombolizing, it is very important to make sure that maintain BP is higher, because very often they just give an antihypertensives and they have to be told repeatedly. Once this chart is clear, then the pathophysiology will be very clear. To highlight this, I will just present one case which I presented earlier also. Smoker and hypertensive. He presented with 3 episodes of transient slurred speech, word finding difficulty, and mild right-sided weakness involving right upper limb. There is no such past history. He himself consumed hypertensives. And when he came, his BP was 120/70. ECG, LVH, MRI below, was given dual antiplatelets. He continued to take antihypertensive despite giving instructions to stop. So he felt that his BP was the culprit, so he kept taking. So this was this initial MRI which showed DWA restriction, and there is some side confusion, I think. Just a minute. Sorry, this is not the initial MRI. So when he came with TIA's MRI didn't show anything. Then the next day he developed left hemiplegia. The next day he developed left hemiplegia and his BP continued to be 100/70. And we gave him IV fluids, and this is the MRA and MRI. You can see the right MCA is totally occluded. So he came with left MCA TIA. In the ward, he developed right MCA infarct. So he gradually improved over next to 4 to 5 days, and his power came to 4/5. This is the CT angiogram. You can see the critical arrow is not going there. Okay, I'll show you the next. Yeah, you can see the critical narrowing of the left MCA origin, left ICA origin. Okay. So in summary, clinically left MCA TIA, right-handed individual, MRI, right MCA diffusion restriction and right MCA stenosis, followed by right MCA infarction, recovered on dual antiplatelets. Left carotid critical stenosis, both MCAs are critically narrow. So should we tackle the left stenosis? If so, when and which method? This patient had compromised circulation on both, so hence decided to intervene on the left side because the right MCA there was intracranial stenosis. So he was on aspirin, atorvastatin 80, olmesartan 40. He was operated on day 17 after initial TIA, endarterectomy done at 12 noon. At 7 p.m. hypotension was noticed, BP 90/70. At the same time, he developed left hemiplegia, power 0/5 on the left side. So repeat CT was normal. What to do next? Should we go ahead with thrombolysis? Should we do mechanical thrombectomy, increase perfusion? All of the above. So we were in a fix, but we didn't go ahead with thrombolysis because of the recent surgery in the same morning. He also received some heparin. So a patient had an endarterectomy a few hours ago. He had a drain, so hence thrombolysis was not considered. So regarding mechanical thrombectomy, so he had a pre-existent right MCA stenosis. So probably this was the reason the intervention was not willing. Plus, in the addition, the relatives were also not willing. They kind of gave up. They said, we cannot do anything more than this. Anyway, we treated him with IV fluids, vasopressin, maintained the pressure. So subsequently, he was discharged after 6 days with the power of 3 to 4/5. He is still now coming. Now he is improved almost normally, not normal, around 4+/5. So this is an important lesson to make sure that the hemodynamics are kept in mind and not to give aggressive antihypertensive therapy in stroke who are not thrombolyzed. Moving on, other lifestyle changes to be done are, one is smoking cessation, regular aerobic and physical activity, salt restriction, limited alcohol consumption, Mediterranean diet and weight control. When it comes to smoking and tobacco use also, there a lot needs to be done, but unfortunately this is not given weightage. All patients who are recently and current tobacco smokers should be counseled to quit smoking. Cigarette smoking associated with excess for all stroke subtypes. Excess risk disappeared within 2 to 4 hours after cessation of smoking. So this is an important, for those patients who are smoking, you have to tell them that if it's 2 years, you are back to normal. The reassuring factor for them, which we need to tell them. And 10 years of life can be gained by quitting smoking. Treat smoking as a chronic disease. Routine screening to be done. Advice to quit tobacco use. Repeated offers of treatment to be made. Monitoring progress over time. Initiate referrals. Initiate pharmacotherapy. And role of clinic staff. See, we may not have much time to deal with these things, but we should make sure that our staff encourage people to stop smoking. And here actually it is less. The Middle East, common practice is 20 to 30 cigarettes per day. It is common, most of them smoke, and that's the amount of, it's a high tobacco content. So most of them are psychologically and physically addicted to nicotine. So it's a 3-step model: ask, advise and refer. Ask all patients with tobacco use. Advise all patients who smoke to stop smoking. Offer all patients both pharmacological therapy and behavioral therapy. Refer them to appropriate team. Proactive outreach program is to be needed. Intervention for all smokers. Assess nicotine dependence. See, one way of assessing nicotine dependence is how soon is a cigarette needed early in the morning. So if it is within 30 minutes of getting up, that means he is definitely dependent heavily on nicotine. That's a clue. So recommend smoking-free home, office and car. So it's a combined therapy which helps: nicotine patch, gum, inhaler, lozenges, behavioral therapy, hypnotherapy, transcranial magnetic stimulation. It's a team effort. It's a patient, family and healthcare personnel. You just can't say that you stop smoking and we continue the same thing. That's not the approach. Now next come to diabetes. As I said earlier, now diabetes there is leniency in HbA1c target. So reasonable goal of therapy is HbA1c 7 and below. So fasting glucose 80 to 130 and postprandial 90 to 180, 90 to 120 minutes after onset of meal. This is the target. In complicated diabetes, the higher target is recommended 7 to 8. In older patients also, higher target is recommended. Whereas in blood pressure, even in older patients, the target remains the same. In diabetics, in older patients, the target is higher. There is another important concept called time and target range. For this, we need continuous blood glucose monitoring. That is, in 24 hours, how much time of the day the patient maintains a blood sugar between 70 and between 80 and 180. That's the time and range. So 70 to 180. This is an adjunct to HbA1c. Goal is 70% of the time to be in target range and less than 4% below range. See, this is one of the clue. If the time in below the range is more than 4%, that means these people are more likely to develop hypoglycemia. So that is one clue. So this continuous glucose monitoring is really useful. In older patients, the target is more than 50%, and the risk of advantages should be weighed against the risk of hypoglycemia. So target HbA1c is between 6.5 and 8. So they found that if the target HbA1c is below 6.5 also, it's a problem. Hypoglycemia is a problem. It's a U-shaped curve. So in long-standing diabetes, difference in outcomes with HbA1c 6.5 versus 7.5 was not much. So some individual pharmacotherapeutic benefits are to be kept in mind. For example, SGLT2 inhibitors and GLP-1 agonists are associated with reduced cardiac events. SGLT2 reduces heart failure outcomes and progression of chronic kidney disease, and pioglitazone increases heart failure risk. So unless diet is changed, diabetes is difficult to control. This is another important concept. See, we see people taking oral hypoglycemic agents, they take SGLT2, but exercise also become more and more beneficial. Snacking to be avoided. This is one very important thing. See, we need to give some rest to the pancreas also. If they keep taking once in 2 hours some tea, bonda, something like that, it is very difficult for the sugars to get under control. So that is why the intermittent fasting concept came up. So you see with the blue line is the conventional therapy and the orange line is the orange-brown is the intensive therapy. So as the years go by, when there is intensive therapy, the percentage of complications reduce significantly with intensive therapy. Now another important aspect is the lipids. This is one thing which is very commonly missed. They are given statin, but the targets are not adhered to very often. So elevated LDL associated with increased risk of ischemic stroke. This is very well known. However, the relationship between high LDL and carotid plaque is stronger. There is no doubt regarding utility of statin in stroke. Only statins have been found to be beneficial. Fibrates, niacin not useful. Effect of statins are due to reduction in cholesterol plus the pleiotropic effects. Even patients with average serum cholesterol level benefit from statin in terms of stroke reduction. That is, let's say a patient comes with LDL of 130, even he will benefit significantly when the LDL target is reduced. So in patients with stroke, aggressive lowering is needed. Target is 70, less than 70. In patients with statin intolerance, maximum tolerated statin can be used along with ezetimibe. Now, PCSK9 inhibitors are available nowadays. I haven't used, but people are using once a month subcutaneous injection. Monitoring is 4 to 12 weeks after the initiating and then subsequently 3 to 12 months. Small increase in hemorrhage noticed, but this was negated by significant reduction in the ischemic stroke. Lower the LDL, greater the benefit. Addition of ezetimibe, very useful. New onset of hypothyroidism in patients on statin increases risk of statin intolerance. This is one point which you should remember. If any patient with statin comes with rhabdomyolysis or very high CPK, one thing we should remember is new onset of hypothyroidism. This classically happened, patient underwent thyroidectomy, and after that patient went into crisis. For patients with intracranial stenosis, target is less than 60. So this is the European guidelines. Some people say less than 50. So when there is intracranial atherosclerotic disease, target is much lower. And this is one of the indications where DAPT has to be given for 3 months. As Dr. Prakash said, not more than 3 weeks. But this is one indication where you can give dual antiplatelets for up to 90 days. Now this is an example of a patient who came with stroke. His admission LDL you see is 160 and his triglyceride is 356. So in such situation, you just reduce the LDL. This was on 18 September. You just reduce the LDL. So gave him a combination of 40 milligram of rosuvastatin plus ezetimibe. Now after 1 month, you see the triglyceride has reduced to 89 and LDL has come to target of 45. So this is the expected target which we should maintain. Subsequently, the statins were reduced from 40 of rosuvastatin to 20. And we'll be checking once in 3 months. So it's very important to keep this in target and to keep the blood pressure also low. So this is a very important concept which we should follow. And lot of emphasis is given to aspirin alone, but this should not be forgotten. So in liver disease, rosuvastatin is preferred. In kidney disease, atorvastatin is preferred. Role of triglyceride as a risk factor for stroke is not as robust as that of LDL. When triglyceride elevation is associated with increased LDL, treating LDL will reduce triglycerides as I showed. Diabetes and alcohol associated with high glycerides is associated with high triglycerides. So you treat these two, triglyceride will invariably reduce. If triglyceride levels are persistently above 150, start omega-3 fatty acids. So in fact, these are more useful than fenofibrate. Weight loss helps reduce triglyceride. General measures like reduce calories from sugar and fat. If triglyceride is between 150 and 500, omega-3 alone may suffice. If it is between 500 and 1000, omega-3 plus fibrates. If triglyceride is more than 1000, then there should be no fat intake. Some people recommend plasmapheresis and initiate therapy only after triglyceride comes to less than 1000. So once more than 1000, more important is to fast the patient, no calorie intake from carbohydrate, no calorie intake from fat. So this is a patient who presented with non-hypertensive smoker. He had TIA a few days ago. This was his triglyceride. You see 3120 was the triglyceride. This was on 7th of October. And then we admitted him and gave just normal saline and told him to fast as much as possible. And 2 days later, you see his triglyceride has come down to 956. So this is one important concept we have to remember. If triglyceride is very, very high, patient has to be admitted because there is an imminent risk for pancreatitis and acute coronary event. So he improved. Unfortunately, subsequently, he didn't come for follow-up. We don't know, hope he's doing well. And regarding HDL, how to increase HDL? Exercise, limit sugar, weight reduction, stop smoking, high fiber diet, moderate alcohol, nuts and niacin. Regarding exercise, 150 minutes of aerobic exercise per week, 3 times of isometric weight training per week, 15 minutes each. Intermittent running is more useful than just brisk walking. Beyond 150 minutes, the benefits are not much. So walking once in 30 to 60 minutes for a few minutes, and people nowadays, all this white collar job, people who are in the IT industry, this has to be emphasis. Once in 30 to 60 minutes, they have to get up and take a stroll. Lunchtime walking and staying hydrated. So this is a very practical advice which we are supposed to give. The other risk factors are OSA, hypercoagulability, hyperhomocystinemia, heart disease, and head and neck radiotherapy also is proposed as a risk factor for stroke. So the take-home points are hypertension is the most important risk factor. Management of hypertension crucial in initial few days as it differs depends on thrombolysis, day of presentation, etc. Diabetes management has become less stringent. Diet is very, very important in diabetes. Treatment of LDL most often reduces triglyceride also. LDL target is less than 70. Lipids and BP to be more stringent than diabetes. And prevention is better than cure. Thank you. Which one, sir? Yeah, it is there. We can use that also, but this latest up-to-date they prefer. They say omega-3 fatty acids is more useful than that. Also can be tried. Not that it cannot be tried. Yes. Yeah, it can be used. In fact, when the target and the triglyceride is more than 500, the drug of choice is fenofibrate plus omega-3 fatty acid. So when it is between 150 and 500, they say the better is to use omega-3 fatty acid alone. And we have to look at other factors also. For example, if we control the diabetes or alcohol intake, the triglyceride reduces on its own many a times.
And wonderful talk. A few questions. What is the fasting duration before doing the lipid profile? 8 hours, 6 hours, or 10 hours?
No, it is 8 to 12 hours. 8 to 12 hours.
And is the fact that lowering of lipids lead to ICH?
No, I showed that also. There was one study which showed that mild increase in ICH with statin. However, it was an insignificant ICH that did not cause any significant morbidity. That was negated by reduction in the overall ischemic strokes.
There are no further questions, I think. Thank you very much, Dr. Prasid.
Thank you, sir.
Very good talk. I appreciate it. Thank you.
Thank you, sir.
Thank you, sir, for reinforcing the significance of comprehensive risk factor management. As a gesture of our affection, may I request Dr. B. Prakash to kindly hand over the gifts to the speaker and chairpersons.
Our concluding scientific session covers surgical interventions in acute stroke management by Dr. Divya Palaniswamy, Consultant Neurosurgeon, Sri Ramakrishna Hospital. We have with us the chairpersons, Dr. M. Vikram, Consultant Neurosurgeon and Head, Department of Minimally Invasive Brain and Spine Surgery, Sri Ramakrishna Hospital, and Dr. Suresh Jayapalan, Senior Neurosurgeon, KMCH.
Good afternoon to all the seniors. Actually, it's good evening. So it's a post-lunch session, so I will quickly finish the talk. So I'm going to talk about the neurosurgical management of acute ischemic stroke. So I think all these topics were covered. The most common is the ischemic stroke, and in adult, the hypertension, and in young, the clotting disorders and all those causes. So, okay, coming to the treatment point, in ischemic stroke, the main we initially the patient comes to the neurologist, they thrombolize, and then in large vessel occlusion they do thrombectomy, or sometimes they do angioplasty or stenting. So even after that, if the patient develops complete stroke, so the next step is to prevent the cerebral edema, cerebral herniation. So here comes the role of the neurosurgeon. So like when there is stroke, like there is edema, so it causes further swelling of the brain, producing herniation, and it may lead to death of the patient. Or if it is not addressed earlier, it may lead to prolonged morbidity. So I'm going to, so in supratentorial, in cerebral hemispheric infarct, we do frontotemporoparietal decompressive craniectomy, hemicraniectomy. In cerebellar infarcts, we do suboccipital craniectomy with EVD. So there are lots of studies to say that the surgical hemicraniectomy is useful in preventing the mortality, reducing the mortality and reduce the morbidity in means more than the medical treatment alone. So there are multiple studies, Decimal, Destiny and Hamlet studies. In these studies are actually prematurely stopped because the surgical hemicraniectomy showed very good outcome than the medical therapy alone. So in suboccipital decompressive craniectomy for posterior fossa strokes, so there are no randomized trial, but Kim et al. Has done a retrospective study. So he recommends this decompressive craniectomy if the cerebellar infarct volume is 1/3 of the infarct, means normal cerebellum. So in cerebellar ischemic infarct, like we know that it may, it's infarct, the swelling may increase, it may produce brainstem compression, reducing the sensorium may lead to death, and also the swelling can cause fourth ventricular obstruction leading to acute hydrocephalus that leads to mortality. So we do suboccipital craniectomy with EVD. So I will quickly finish with 4 case scenarios. So this is 61-year-old gentleman presented with sudden onset of left hemiplegia with drop in sensorium. So the patient MRI was done here. So it showed a right MCA territory infarct involving more than 50% of the MCA territory volume. So the MR angiogram showed. So this patient, like actually his sensorium was actually E2, V2 and M5. So we proceeded with the, means he crossed the window period actually when he came here, and it's a large vessel occlusion, complete infarct. So we took him to theatre. Emergency decompression was performed. So so the emergency decompression was performed. So the next day, the patient was ventilated overnight. This first scan is the uppermost scan is the first post-operative day post-operative scan, which shows actually established infarct in the complete MCA territory infarct. Right time we have done the prophylactic decompression, and the patient GCS improved to E3, VT and M6. So in the serial CT scans also showed there was not much of a midline shift, and his sensorium also improved, and he was extubated on the 3rd post-operative day. Patient was shifted to SDU step down unit and then to the ward, and he was started on oral feeds and physiotherapy was started. But on the 10th day after the surgery, patient develops desaturation. So the CT was repeated. There was small hemorrhagic changes in the CT scan, but however, like the echo showed right atrial thrombus. So the deep vein thrombosis was suspected. Doppler study proved presence of deep vein thrombosis. So the patient was started on actually anticoagulant. So the next day morning, when the scan was repeated, like he had the patient, but there was no drop in sensorium, but the patient had further hemorrhagic transformation in the already infarcted area. Hence the patient, the anticoagulation was stopped and IVC filter was placed, and the patient actually without any problem, like he recovered over time. And after 15-20 days, like patient was discharged, and Jesus was 15/15, and after 2 months he came back. When this is the scan, there is no pointer here, so he came for actually cranioplasty, and the cranioplasty was done. The bone flap was kept in the abdomen and means abdominal wall, and it was replaced. Autologous cranioplasty was performed after 2 months. The patient actually is doing very well. Coming to the second case, a 41-year-old gentleman present, means he is a known case of CVA 1 year ago, but actually he was not on regular antiplatelet therapy, he not on regular follow-up. Like he suddenly presented with giddiness and headache, and MRI was done. MRI showed a right cerebellar infarct, acute infarct, but there was no mass effect on the fourth ventricle or the brainstem. DSA was done. DSA showed left vertebral artery origin occlusion and also right side P3 segment occlusion. So Muthurajan sir did the clot thrombectomy and stenting of the left vertebral artery. After 2 days, however, the patient actually developed drop in sensorium E2, V2 and M5. So the CT was repeated. It showed increase in the edema. There was no increase in infarct size, but there was the already infarcted region has caused cerebellar edema. It has caused fourth ventricular obstruction, and there was hydrocephalus. So he was taken up for posterior fossa decompression on the right side. So and EVD was placed. So after few days, his sensorium also improved, and after 7 days, like slowly we repeated the scans serially, and there was reduction in the cerebellar edema and opening of the fourth ventricle. So the EVD was removed on the 7th day, and he did not develop any hydrocephalus. However, this patient actually developed complications related to EVD infection and this thing. He's on treatment for that. So coming to a 21-year-old lady, known case of systemic lupus erythematosus, lupus nephritis and nephrotic syndrome, not on treatment. She was taking actually native medicine for 2 years. So she presented to the nephrologist with the complaints of recurrent episodes of hypoglycemia and hypotension, and she was also suspected to have intestinal vasculitis. So after admission, like she was started on methylprednisolone, and after 3 days she developed drop in sensorium. So here also the MRI was done, CT was also done. CT showed bilateral cerebellar hypodensities with the fourth ventricular obstruction and hydrocephalus. MRI showed patchy infarct in the cerebellum, multiple small infarcts in the cerebellum and pons, and also in the right thalamus. So this patient actually we planned for posterior fossa decompression with EVD. However, on table when the patient was put on prone position, she developed actual desaturation. So urgently we did EVD alone. I couldn't do the posterior fossa decompression. To her surprise, then actually she developed intraoperatively pneumothorax. So that's why the desaturation happened. So we didn't do the posterior fossa decompression, performed only the EVD. But to her surprise, the next day, like her sensorium improved to 10T/15, like she was conscious, obeying commands, and ICD was put immediately after coming to the ICU. And actually she was started on cyclophosphamide therapy, which really helped. And actually after 2 days when we did the CT scan, the cerebellar edema has come down very well. And on the 7th day again the EVD was removed, and she took treatment for 20 days in the hospital by the nephrologist with the cyclophosphamide therapy and all those things. It took long time for her to come out though. So this is one child, a 13-year-old boy who met with an accident, road traffic accident, two-wheeler versus two-wheeler. So when he was brought to the hospital, like his Jesus was only 4/15. So he was intubated, ventilated, admitted under the PICU consultant. And after intubation, CT scan was done. It showed a bilateral diffuse SAH, diffuse cerebral edema, and there are multiple fractures. But however, there was no exact midline shift, and it was bilateral cerebral edema. Like we continued with the ventilation. Actually, his Jesus improved to E2, VT, M5. And he had mild hemiparesis on the right side. He also had CSF rhinorrhea, but it actually was managed conservatively. So on the we repeat CT scan showed mild reduction in the edema. His sensorium did not drop. So we continued with the medical management and ventilation, everything. But on the 4th day, suddenly in the morning, he developed drop in sensorium with pupillary dilatation on the left side. So CT scan was done, which showed a large left hemispheric infarct, IC8 territory infarct, and there was a established right basal ganglia infarct also. And CT cerebral angio was done. It showed a left petrous segment carotid occlusion with no flow distally. So this child actually was taken up for emergency decompressive craniectomy, and while performing the surgery decompression, the patient's actually brain was oozing out. It was bulging so badly, and we had to close the scalp very fast. So I explained the poor prognosis and everything to the child's parents. So this is the MRI scan which showed left side petrous segment of the carotid was completely gone. Actually, he had ICA dissection, carotid artery dissection at the level of petrous during the injury. So that has caused complete occlusion with left ICA territory infarct. However, in the angio, like we can see that the fetal PCOM is filling the distal MCA on the left side. So this MRI was done later. However, his sensorium actually improved. So to our surprise, his sensorium improved to E2, VT and M5. So on the 5th day, actually patient was extubated without even tracheostomy. The child came out, the decompression really helped. So and then he was started on aspirin, but he developed some RT bleed, bleeding in the intestinal bleeding, RT aspirate, bloody aspirate was there. So we stopped the antiplatelets also. So slowly the child recovered, shifted to ward, and after 1 month he was discharged, and his sensorium improved to almost like he was able to speak only few words, and he was able to walk with support after 2 months. So he came back to the OPD. Like this is CT scan showed development of hydrocephalus in this child. So though there was gliosis on the left side of the ICA territory, but there was hydrocephalus also. So I did VP shunt at the same time with the autologous cranioplasty. So the child is doing fine. So these are the 4 cases I presented, different cases. Thank you, sir. Thank you.
Thank you. Nice collection of cases and surgery.
You,
just one, maybe for everybody to know, when will you do the decompressive craniectomy? For example, the GCS, do you have any cutoff points or
sir,
just
yes,
a volume?
Sir, it is depends on the GCS of the patient and also volume of the infarct. If we take an elderly patient, 80 years old with a lot of cerebral atrophy, she has enough space for the edema to accommodate. So I wait, sir. Though the GCS doesn't drop much for those patients also, I follow up. But if young age with actually more than 50% infarct volume on right side, so I advise actually prophylactic decompressive craniectomy. On left side, yes, so the prognosis, even post-operative outcome, morbidity is high. So I explain, the patient may not speak or they may develop dysphasia and all those things. If they're willing for the surgery, I go for prophylactic decompressive craniectomy.
That's what, because in our during our studies, we used to do only the unconscious patient decompressive craniectomy and all. Okay, but nowadays it has changed. Even a conscious patient with a large volume, we tend to do with the good results.
Yes, sir.
That's a good thing.
Yes,
thank you.
Thank you, sir.
I think again the same. When we do decompression early, the penumbra perfusion improves. That too, if it is a young patient where the volume of normal brain is huge, when we give a decompression early, though the necrosed area is not going to survive, the penumbra perfusion improves and their outcome is always better. It depends on the volume of the brain and the size of the infarct. So that matches our decision. And again the same, in the post-fossa we don't have any option. Even if it is a small infarct, better to go for early decompression, because anytime suddenly they cone, their outcomes are not as good as what we expect when it is done early. Thank you. Any questions from the floor?
It's not a question, it's only comment. So I remember years back, we had one young stroke, left side large infarct, right hemiplegia. GCS was low and referred the patient. Dr. Murli was there that time, and this about 20 years back, I think. We did craniectomy, patient survived, started walking, everything fine except that loss of speech. One day Dr. Murli got a letter from the patient dictating, and the attendant wife wrote the letter, I believe. Sir, என்னை உயிரோடு பச்சிட்டிங்களே இப்படி நான் விட்டுருந்தா செத்துருப்பேன், பேசவே முடியல. No, just the left side infarct, I just can't forget it. Murli showed me the letter. This is what they had written. And that's what I come for the review also. I told him, you are so good, so nice, you are walking. And, he was telling his wife, I could not understand. A wife translated, sir, irundhu enna sir prayojanam, pesave vekkaliye, vittunda na poirupane, yen sir ipdi enna panneenga? That's the answer I got. Okay.
Decompressive on the left side massive stroke. But here it is not in our hands. We have to tell the family, and if they agree, we have to proceed. Otherwise, medical legal problems are there. And obviously, they are going to pay.
No, the other problem is, no, this, in fact, right-sided strokes are more disabling. They'll be able to speak, but they'll never come out of hemi-neglect. That is even more troublesome. So sometimes it is better that these people at least will cooperate for physiotherapy. Only thing they cannot speak, but they know what's happening to them, they'll cooperate. The right-side people will never cooperate for anything, physiotherapy, anything. They'll never come out of neglect. It's a bigger problem. So sometimes managing non-dominant side is more difficult than managing the dominant side. So I think that concept of because of aphasia not doing, I don't think is valid anymore. So non-dominant side is evolutionally supposed to be higher than the left side. So non-dominant side is like parallel processing and dominant side is like serial processing. Men use more of dominant, women use more of non-dominant. That's one of the...
I think women use both the sides, sir.
Yeah, that's why they fight more also.
Thank you. Thank you, sir. Thanks for the organizers also.
Thank you, ma'am. Thank you, ma'am, for the thorough wrap-up of acute surgical interventions in stroke care. As a token of our affection, may I request Dr. K. Ashokan to hand over the gift to the speaker and chairpersons. May I request Dr. Kannan to give the gifts to the speaker and chairperson. To wind up today's stroke symposium, may I now invite Dr. K. Arunadevi, Consultant Neurologist, Sri Ramakrishna Hospital, to render the vote of thanks.
Good evening all. First of all, I thank all the delegates for having stayed so long after the postprandial session. I thank our managing trustee, the joint managing trustee, the board of trustees for their involvement and their unprecedented support for this event. Next, I thank our CEO, CAO, our medical director and medical superintendent for their continuous cooperation and their suggestions for planning this event. I thank our chief guest, Dr. Lakshman Narasimhan, for having come down so much from Chennai amidst his very busy schedule for our event and also for giving his wonderful talk on AI. I next thank our speakers for sharing their knowledge and making this event very interesting. I also extend my heartfelt gratitude to all the neurologists and neurosurgeons from the other hospitals, general physicians, PGs, and other doctors from in and around Coimbatore for having attended this event. I thank the Genova company for having partnered with SNR Trust for and giving us their help in logistics and for also having conducted this, helping us to conduct the event. I thank the PR department of our Ramakrishna Hospital for they were along with us throughout the planning and event, and I thank you all, the team, PR team, for supporting this event. I also thank the masters of ceremony, both of them, for a very good scintillating mastering and running through the event nicely. I thank the Residency Hotel and the AV staffs, everybody, for keeping a smooth event. Thank you one and all. Thank you.
Thank you, ma'am. With this, we conclude the Stoke Symposium. Wishing you all an inspiring week ahead.
No, before dispersing the one thing, next week Sunday evening 7 to 8, we have got a meeting. My Professor K. Srinivasan from Madurai, he wants to address the mainly students and of course all the consultants. Basic clinical neurology, bedside neurology. He is going to talk for 45 minutes, 1 hour. He is very much interested. Most of you must be knowing about him. He is already 92 years. Still he is into teaching and he loves teaching and he lives teaching. Okay, he is coming down Sunday. He wants to teach you all. Please spare your time and attend Sunday, coming Sunday, 16th, 7 to 8 at the hotel, Welcome Hotel, Racecourse. Thank you. All of you are welcome.
Let us all raise for the national anthem.
जन गण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे